So from a balance perspective, balance issues is, if you're trying to address balance, that's a huge, broad statement. Many things affect somebody's balance. It's a very holistic, if you will use that term, thing to address. And today, mostly we'll be talking about assessment, how to evaluate a patient, how to figure out what's going on, which is not a small task. For me, you want to look at not only what the problem is and that they have a balance problem, but you have to fully assess them to figure out are there any reversible causes, and then figure out how to treat it. And during your assessment, during your evaluation, I'm also establishing a plan of care. Now tomorrow we'll go more into detail, much greater detail on the vestibular system, which is it's a very complicated system. So we'll touch on it today, but we'll go into much more detail tomorrow. And then tomorrow we'll go a lot more into overall treatments, establishing a plan of care, writing goals, and then various interventions that you can do that have been shown to be effective, and how to be creative as well. Make it fun, because it's not enough to just treat somebody. If you want them to do persistent and ongoing things to reverse their problems, it's got to be somehow rewarding to them and hopefully enjoyable. This is my personal email address. So on the front of your handout and most of the handouts, it all has the JDB Enterprises email, and I'll get it if you send it there, but this will come directly to me, and then I can respond directly back to you. It might be a little bit faster. This will be if you have clinical questions. If you have more questions about your certificate or something like that, do the one on the handout. But if you have clinical questions or research questions, anything like that, go ahead and send it directly to me. So we're going to talk a lot about standardized tests. Hopefully you're already doing a lot of standardized tests. Whether you like it or not, we have to, especially if you're billing Medicare. But I'm a pretty big fan of standardized tests. I wasn't necessarily from the start, but I definitely am now, and I found great value in many tests, because for me, once I do some of these standardized tests and I see how the patient is performing and what's the problem or what areas they have more of a problem with, that's evaluating them for me. It's very smart people have created these tests for us, and these tests give us usually very well-rounded picture of the patient. And if they do poorly on an area, you may further explore it with an additional test. But it also helps formulate your plan of care. So a lot of times those tests are super helpful in helping you come up with a treatment plan, goals, and then again proving that what you've done is effective, because you then repeat the test and it shows you that you had a good outcome, that progress is being made. For me, there's a lot of resources. If you go on the internet, you will find many research articles, and you'll find a lot of different databases and sources for information. Sometimes to me it's too much. You have to pick one and go with it. One of my favorite places to visit, and that I recommend a lot, is it used to be called rehabmeasures.com, which is the former, I can't think what it's called, but right, it's changed names. And so it's Shirley Ryan Ability Lab. If you go on there, you'll have lots and lots of resources of rehabilitation standardized tests. So you can go on there and plug in the problem you're trying to address or the specific test you're looking for. And the majority of them are not only available on there, but they're a full description. So skilled clinicians have gone on and looked at them and given you a brief overview of the test, who you might use it on, why you might use it, validity, testing, things like that. And then it'll give you a link to the test, so you can click on it and it'll take you to a printable version of the test that you can use for yourself. Occasionally there's a test that's not available because of copyright protection. It'll give you a good overview of the test, but you won't be able to get the test itself. Some companies, you have to purchase the test. That's getting more and more rare these days, but occasionally you'll run into that situation. I don't get that, but I'm not the one publishing them. So this slide just reminds me to talk about the idea that as we age, certain resources start to diminish. And some of them, no matter how good you take care of yourself, or how healthy you are, there will be some changes that occur that cause your resources to diminish. From a vision and all your sensory feedback systems, your range of motion, your strength, and so forth, you will start developing some deficits and have some decline, but it's variable. And many of these things don't have to happen as quickly as they are because there's pathologic changes that sometimes are preventable and reversible. But you know, your general population of elderly, they've got a slight decrease in all these resources. And some people, they have a severe decrease in one or two of these areas. So your challenge is to figure out why are they impaired, what is impaired, is it reversible, can you restore it, is there something you could do about it, or is it irreversible and therefore you need to compensate for it. The big decision when you evaluate somebody is if I compensate for something, they're not going to get it back. They're going to continue to function without it, which I would always rather restore if I can. So if there's something reversible, you want to figure that out and establish a plan to reverse it. But you also don't want to spin your wheels and waste your time and resources on something that's not reversible. So being able to evaluate somebody and try to set realistic goals and options that are going to use our resources to the best possible, and also get the patient as safe as you can, as quickly as you can. What happens is as their deficits, you know, as their resources decrease, they very often will compensate and decrease what they do. And so they'll self-impose restrictions. So some of these self-imposed restrictions they'll stop doing as much, and then they'll lose more resources, and then they stop doing as much and they lose more resources. So this is how it often happens. On occasion, which is the people we usually run into, there's a sudden change. A lot of times there's a sudden change and a sudden loss. And the way they bounce back from that requires good direction, because many people won't bounce back very well because they just don't know how. They don't know what to do and how to do it, and therefore a hip fracture becomes they're non-ambulators and they're no longer community involved anymore. Others will, if with the right direction and the right rehab and the right motivation, many of them can resume. So that's where our job is, to figure out what's repairable, what's restorable, how do you motivate people. That's, you know, all these things are a big part of our job. How many of you are PT or PTA? Okay. OT, CODA? Okay. We got a good mixture here. Takes a, what does it say? Takes a village? It takes a team for us to definitely get things done. So when you think about all the reasons people may fall and all the deficits they may have, we could break it down broadly into intrinsic and extrinsic. You'll see that a lot. Intrinsic are things within their body. Their vision is impaired, their range of motion is impaired, their strength is reduced, versus extrinsic, which would be the medications they take, the world around them, you know, their home or the environment that they're in, if they're in a hospital or a skilled nursing facility, that type of environment, that would all be extrinsic things. What they wear, poor footwear, common problem. All of those things would be extrinsic. And so sometimes you're going to break that down into intrinsic and extrinsic things. And some, arguably, the extrinsic things might be easier to change, but maybe not if they're not compliant also. So those are just a broad breakdown, and we'll go through all the detailed different things, both intrinsically and extrinsically. Don't look at your book yet. What's the number one thing? There's one question you can ask that's going to be the best predictor of whether they're fall risk, and that's have you fallen. So basically, have you fallen in the last 12 months? But you know, you have to ask it right too, because many people don't consider it a fall. Where they'll say, you know, I may be tripped, you know, an almost fall, or I would have fallen, but my spouse grabbed me and I didn't fall, or yes, I fell, but I fell on the bed, so that doesn't count. You know, so some people don't want to count it. And the question I always think about, and I often will put it in my documentation, is that this person has had how many falls and the mechanism of how they fell. Because, you know, I've fallen, and it's not that I'm at risk for falls, it was an unusual event, you know. If you put yourself into high-risk situations and you fell, or it was an unusual, you know, they were drinking at a wedding, and it was an unusual thing they don't usually do, and they had a fall. Or they slipped on a grape in the produce section of the grocery store. You know, those are unusual events, and those are not your typical. But someone who fell doing their routine, their daily routine, that's someone who's much, much more likely to fall again. And they're also very likely to self-limit and just get worse and impose restrictions on themselves. So asking the question and asking them, you know, were you injured or have you had any slips or trips or close calls? Bless you. So when we think about as we age, some of the things that occur, musculoskeletal changes, we start to develop muscle less, it's harder to build muscle and it's easier to lose it, put it that way. Many of us already know this, all these things are kind of starting to happen, but I say lower extremity strength because that's going to affect your balance the most. Upper extremity strength decreases as well, and actually grip strength is a good predictor of falls, which seems right. A lot of patients are like, you're checking how tight I can grip, and you're looking at my balance, walking balance. But they actually are related. So an overall decrease in strength is predicted by grip strength is one of the many ways you can look at that. And so yes, many things are good predictors. But when you look at lower extremity strength, the quad strength and the glute strength, it's a big predictor of falls, and it really causes these folks to have the most impairment when it comes to transfers and ambulation. As you get older, you have less lean body mass and decreased strength. It most affects you at your hips and ankles. Those are going to be the biggest impact to your balance. Range of motion deficits. You start losing elasticity. The type of collagen you have present in your body starts to change, and you become more fibrous and less stretchy and elastic. It's especially going to be affecting you at your hips and ankles again. So when you start looking at your plan of care and you really assess somebody, you want to focus on hips and ankles. When we talk about that as we go on, and when you're practicing these things, whether it's with me at the end of the day today or at home, one of the challenging things is assessing hip extension. And I find, I don't know about you guys, but I find a lot of people don't. I'll see somebody being evaluated and they'll have the patient flex their hips, especially if they're in a wheelchair or sitting edge of bed, but they don't always assess hip extension. Well, I get it. It's not easy to do. It's difficult. But we've got to address it and we've got to look at it. So hip extension, hip abduction are arguably more important than hip flexion, which is more often assessed. So we have to be looking at hip abduction, hip extension when it comes to sit to stand, when it comes to standing balance and ambulation. So we've got to figure out a way to work it into our evaluation in a way that's going to be effective. So we'll keep talking about those kinds of things. Postural changes as well, degenerative changes. Many people begin to develop a forward shoulder, many of us as well. I know when my patients, when we're doing the extension, thoracic extension and shoulder external rotation, I do it with them because we're all subject to the same degeneration type changes, and we spend our lives in a forward position. And so many people develop pec minor, especially, I find is very, very common. I specialize in spinal cord and brain injury. So I work in a facility, which I didn't even talk about that. My place of work right now is I'm the rehab director at a facility called New Life. It's in a little north of Orlando. And we treat all neuro. So everybody that comes to our facility is some sort of neurodiagnosis, either some sort of brain injury or spinal cord injury. And especially spinal cord patients who are wheelchair bound, tend to be very, very tight. But across the board, most people who have been disabled and in bed or in a wheelchair for a period of time have tightness of their hip flexors, and they have tightness of the anterior portion. They're limited in thoracic extension, shoulder external rotation, even their cervical area. A lot of times they're in the forward head position. So it's super common, and it causes many problems, whether balance issues or pain. And so those are things that we need to look at. Now, from your typical elderly population, a lot of them develop a kyphotic type position. Much of that is simply due to the same thing that's causing us with us. They're not doing daily motions. Our daily motions don't involve this type of maneuver. It's just they are forward. And so we have to help develop daily programs and daily habits that are going to promote a better posture. Now, from a neuromuscular changes standpoint, some of this is all going to come together because everything works together. A lot of people will talk about how they don't realize their toe will affect their finger. You know what I mean? And how the whole kinetic chain, the idea that your ankle motion will affect your posture. And if you don't have good strength and you don't have great function when you're reaching, everything works together. So it's all connected. The kinetic chain completely affects each other up and down. It also is all affected by your sensory feedback systems, which we'll talk about next. And everything becomes a little slower. As you get older, you get less input. The time it takes to receive that input, for it to get to your brain, have you process it, and then to be able to react, it all starts to slow down. So reaction time slows down. You start to have impaired postural responses. It takes longer. There's a delay, there's a latency in the time it takes to receive the information and for you to respond to it. Poor coordination and muscle activation, this is related to a number of things, but even someone who's just generally older and there's an overall decrease in all their feedback systems, it's just the ability to process it, get it, react to it, and process it. Sometimes there's a poor anticipation of postural transition, so what you need to do to be ready to go, the ability to, you see the problem coming and you react to it quickly and you're prepared, becomes decreased. There's a time lapse there. You also start, when I say impaired sensation, this may not be a pathological impairment. It may just be a general decline in overall sensation. And that's not just your feeling in your fingertips or your toes or your feet. It's your vision, your hearing, your vestibular system, proprioception, everything kind of just decreasing a little bit amounts to lack of ability to maintain the balance and meet increased challenges. And this all results in increased postural sway. So one of the things that I want you to pay attention to is as we go through the day and we talk about individual items and how they decrease as you get older and how that is going to be tested. Because when we start doing the standardized tests later, if you don't already do this, you'll be going, oh, I see, this one's looking at postural sway, and therefore postural sway increasing is all because of these things. It's because your sensation coming in, the information, there's a delay. So what happens is we're all a bunch of bobbleheads. All of you are. You're really good at it, because I don't see anybody's head going like this. But I'm sure you've seen that before, right? You've all seen the people whose heads are going back and forth. Basically, all of us are constantly trying to balance your kinetic chain. So right now, you're balancing your head on your shoulders. We're looking good. Not many of you are resting your head on your hands yet. But many times as the day goes by, I see everybody kind of, start resting. But you're balancing your head on your shoulders at the very least. And then if you sit unsupported, if you scooted to the edge of your chair, you'd be balancing more of your body on your, on your bottom. And then as you stand up, I can be balancing my body on a wide stance, so that's my basic support. Or then I'm balancing my body smaller, or 1 foot. So a lot of this goes into the how big is the challenge and your postural sway. So what happens is when your body starts to move one direction, or in your cases, even just your head, it's moving in one direction, or back and forth, your body senses this through your vision, your vestibular system, your somatosensory system. You're sensing that your head has gone this direction, and you correct it. You bring it back this way. And what happens is as you get older and all that process is slower, there's a slower period of time to respond to it. So your head starts going this way. You don't respond as quickly to bring it back. And then when you bring it back, again, it's maybe a little overshot, and you don't react as quickly to bring it back. So when you get your whole body up on the feet, the postural sway becomes a little bit more challenging. So your whole body weight is moving forward, backwards, side to side. That's postural sway. And the idea is as your resources become less reliable and less quick to respond, as your processing becomes slower and less of it, the sway goes up. The amount of time it takes you to perceive that you're swaying backwards and then react to it. We've all seen people doing this, right? Like balancing, maybe at an event where there's a lot of alcohol intake, and you start noticing people, their sway is going up. But some people, it's the elderly who just don't have as quick a responses and as good a resources, and they're trying to stand, but they're challenged. And so their different resources are being challenged more. And at some point they don't meet the challenge, and then they can fall. So when we look at the kinetic chain and we think about this, I think your person didn't show up very well in the picture. If you're artistic, you could draw that in, or you could do a little stick figure, whatever you want to do. So basically, when we think about the kinetic chain and how everything affects itself, and think about a forward head. If you had a forward head, if you have thoracic forward, you're going to automatically have to shift your body backwards, because that's going to bring your center of balance forward. And as a corrective action, you're going to have to bring something backwards. So you're going to shift your weight. The complete opposite end of the chain is if you have tight ankles, if you have a lack of dorsiflexion and you can't get to neutral. You're automatically going to have to compensate somehow. If you want to stand up and you can't get your ankles into neutral or maybe even 5 degrees of dorsiflexion, your body's going to be pushed backwards, and so you're going to have to do something, and may create a forward head, bend at the hips, something to do to compensate for it. Well, right away, your balance isn't going to be as good, and your standing activities are not going to be as safe or efficient. You're going to get more tired. It's going to involve more of your cognitive, you're going to have to think about it and try to maintain it, so you automatically aren't going to be able to function as well in that position. And so moving along down the chain, the same thing would happen with anything. You want to think about how any one change can have an effect up and down the kinetic chain. Let's go ahead and stand up for a second. Those of you at home, too, stand behind your chair. I'm going to make you guys keep getting up and down so you don't fall asleep on me. So, if you stand behind your chair, that way you have something to hold on to if you're going to fall. Don't fall. Just get comfortable, feet maybe hip width or so apart. Just start to shift backwards. What's the first thing you feel happening? Do you feel your toes come up? You feel your toes come up? Okay, so you're feeling your balance go back and you're feeling your toes come up off. If you keep going backwards more, then what happens? Then your whole forefoot comes up. You go all the way up on your toes. That's your ankle strategy. So your ankle strategy from that standpoint. Now stand on one foot. Ooh, did you see me bobble a little? So stand on one foot. What's happening now at your ankle? You feel a lot going on, a lot of inversion, eversion. Also forward, backwards is not as obvious because right now your brain is saying, wait a minute, this is challenging. So you're going in and out. So those things are your ankle strategy. So when we start talking about strategies, when you evaluate a patient, a lot of times I'll look right to their feet. If I have them standing up and I'm looking at their standing balance, I look right at their feet and I'll immediately say, poor ankle strategy. Toes, lack of toe mobility. You know, a lot of your older people, we're going to talk about neuropathy here in a minute. Their toes are what, like this? Because they've already got some neuropathy. They're not going to have good toe strategy, if at all, any toe strategy. They might not have any ankle strategy whatsoever. Somebody who's fused at the ankle clearly would not have any, if not very diminished ankle or toe strategy. So that's your ankle strategy. So if you start to go further back, use up your ankle strategy, and then go a little further. What are you doing? What do you do? Step. So you step. Anybody else do anything else? Your arms maybe come out, your hips come forward. Okay, so you used a hip strategy. This is where it's different. Everybody kind of learns to compensate differently. So you have ankle strategy, which is our best strategy we've got. You can stand there and everybody in the room doesn't know how you're working hard because your ankles are doing a great job. But if you don't have an ankle strategy, all of a sudden you're dependent on others. So what do? A lot of times feet come apart because they can't balance side to side. They may be going, so if you start going forward and backwards and you notice your muscles are working a lot harder, so it's exhausting. They're trying to balance, but they're using, instead of these nice, efficient little muscles, and they're working really efficiently, their body is not efficient. And they're having to use their big muscles in order to balance. So you've got your hip strategy. The knees don't help much because they only bend, they're hinged. They don't really help. Your hip, because it allows you to move in different directions, but what if you have a hip flexion contracture? That strategy is not going to be as helpful because the hips already are limited. And then they're using a trunk or arm strategy. And then usually last but not least is a step. And they may not have that. So as we go into assessment, that's one of the things we'll be working on is step strategy and assessing whether they have it or not. Okay, you can sit down. I'll make you stand up again in a few minutes. So basically, when I evaluate somebody, I'm putting these on there. I'm looking and I'm saying, poor ankle strategy, utilizing step strategy or utilizing arm strategy, unable to perform, whatever tests we're doing without use of hip and arm strategy, wide base of support. All of those things I'll be putting in there, and that way it's something I can look at, and you can start down the road putting it as an improvement and more efficiency as well. Questions? No? Okay. So let's talk about sensory feedback systems. Our sensory feedback systems, the primary ones that really affect your balance are the vestibular system, the somatosensory system, so sensation and proprioception, and your visual system. All of these matter. They're all important. What happens is as we get older, what's typical of just general age, but no major pathology, they're just getting old, is it's typical that all of these start to decrease. But what can happen is somebody they lose one altogether. Somebody goes blind. They lose all their vision. And so think of it as a chair, You can function without one of these if the other two are really, really, really good. But you can't function if all of them aren't working pretty well. So if you have a slight impairment of all of these, you're going to have some challenges. You're not going to be as efficient. You're not going to be able to do as many high challenging things, like going out in the community and playing pickleball or whatever it is that they want to do that they can't do safely. But then if one of the systems gets significantly impaired, that's going to really affect their balance, and that's where you want to identify it and decide, is it reversible or is it not, and set realistic outcomes. Okay, so let's look at each one of these separately. Let's briefly talk about the vestibular system, and then tomorrow I'll go into much more detail. So all of these, your vision, your vestibular, your somatosensory, they all have a peripheral component, which is the data collection area, and then you have a central component. So all the data that's collected from these sensory feedback systems is sent into your neurological system, where it's processed and you become perceptive of it and you react to it. Some of it is reflexive, but a lot of it is you get the feedback and you react to it. From a vestibular standpoint, the peripheral component is in your ears. So it's your inner ear. You have two sets on each side, and it looks like this, but this is huge. They're very, very small. And the interesting thing is, so I graduated in '91, which is not all that long ago, but we know a lot more about many of these systems than we used to, because all of these small things that you have in your body they're not easy to study. But now, as technology gets better and better, they're better able to kind of look at these different microscopic things and assess and figure them out. I have tremendous respect for some of the early researchers who, without great objective information about these different systems, who were able to figure out how to diagnose and treat people, is just amazing and wonderful. So when you look at the vestibular system, you have your semicircular canals, and you have your utricle and your saccule. So these are basically often called your otolith organs. And the utricle and saccule, again, we'll go into more detail, but they are, one sits this way, one sits this way at a 90-degree angle to each other, and they're meant to pick up linear information. So you're in an elevator. Visually, you can't tell what's going on around you. If it's going really slow especially, there's not much physical feedback that you're going to get, but you can tell because your utricle and saccule are giving you that information that you're moving up or down. Also going forward and backwards. So if you're on some ride or in your car, have you ever been in your car and the car next to you started moving either forward or backwards and it freaked you out because you weren't feeling it yourself? But that's the part of your body that perceives that linear motion. And your semicircular canals, they pick up rotational motions. And so the way they're lined up is they're really meant to pick up very, very complex movements. The problem is the only thing you're getting from your vestibular system is what's happening with your ear, basically, what's happening in your head. So it's telling you whether your head's moving this way, that way, forward, backwards, and it's very, very precise if it's working properly. But it doesn't tell you, is your head like this? Or did your whole body go like this? Or did the whole room go like this? You know what I'm saying? So it basically only tells you what happened with your head. It's up to your vision, your somatosensory system to tell you that your neck's side bent, or it didn't. Your whole body side bent, or the whole room side bent, or the whole room shifted. So your vestibular system, though, will give you very precise information if it's working properly. If you have a mismatch, so your vision tells you one thing is happening, but your vestibular system tells you something else is happening, that can amount to some degree of, well, it could amount to symptoms of nausea and not feeling well, and it also can amount to dysfunction, you can't balance. So you may not feel well, you also can't balance, you can't function, it's very disabling. So anybody who's ever had a patient with a significant impairment of any of these systems can see how disabling it is and how life-changing and uncomfortable it is. So if we can address those, that's great. So if you have somebody, now the thing about the vestibular system is if something's going wrong with it, they will have illusions of motion. They will have, so when we talk, as we go through the day today, one of the things we'll do at the very end of the morning is we'll do just a few summary type things, and one will be differential diagnosis of dizziness, a complaint of dizziness. So a lot of patients will say, I'm dizzy, or I feel disoriented, or they'll give you some word for feeling dizzy. And one of the best things to ask is like, are you lightheaded or are you spinning? Describe your dizziness. Is the room spinning? Are you feeling like you're moving up or down? Do you feel like you're floating on the ocean? If they describe that and they describe it, it's more of an illusion of motion, like spinning, floating, going up or down. That is vestibular. And that'll help you know that that's what we need to look at. If all you've ever had, and you're not real good at the vestibular system, and if this is all you've had, send them out. Get them assessed by somebody who is more skilled at the vestibular system. We all have our toolbox. We all have our strengths. We all have things, like there's things I'll encounter, I'm like, oh, we're gonna have somebody, I'm gonna have to refer you to somebody, because this is something that another therapist might be good at, but I'm not where I need to be on this. So know that if you have somebody who has a vestibular issue, and you're seeing things like nystagmus, where their head is stationary, but their eyes are darting in some direction back and forth, that's another vestibular indication. And you don't know what to do about it, or you're not sure what's causing it, get them a referral. So tomorrow we'll go into more detail. I know some of you guys won't be here tomorrow. So that would be what I would do in that case. Okay, so the semicircular canals are going to pick up motion in a variety of different directions by the way they are lined up. So one of them, it's this direction. It's this non-linear direction. One is this direction. And so one is more of a head over heels kind of direction. So they're all, the combination of the 6 semicircular canals, 3 on one side, 3 on the other, is going to give you very complex feedback about how your head is moving. And it coordinates with your eyes. So we'll get into more detail about that tomorrow as to how to be able to look at their eyes and see a lot of information about the vestibular feedback. Okay, so let's talk about vision. If you have vision, the majority of people with good vision are very dependent on it. They don't even realize how dependent they are. Because you see everything well and you tend to function in a high light inner environment, and therefore you become super dependent on it and you don't use all your other resources. You guys want to get up again? You're already up, so you started the ball rolling. Let's go ahead and get up again. So let's do something. Just to see how dependent you guys are on your vision. If you might spot each other too, just for the very first part. So remember how we stood on one foot? I want you to try standing on one foot with your eyes closed. But watch your partner for just a second, just to make sure nobody falls over. I think we'll be pretty good. So far, it looks like everybody's got good strategies. Harder than you would think, would you agree? Okay, so when you close your eyes, now just lightly touch your hand, not physical support, but just rest your hand lightly on your chair with your eyes closed. Do you feel a difference? Is it easier? Is it easier than you thought it would have been? Make a big difference, I agree. So basically just that tiny little bit of feedback is telling you so much, because the sensation in your hand is giving you a tremendous amount of feedback. But are any of you surprised how hard it is to stand on one foot with your eyes closed? No, you're not surprised.
I'm surprised that I have better balance on one foot than the other.
Okay, so you're,
One is better than the other.
so you have better balance on one foot than the other. Is it the same as your dominant arm? Or is it opposite?
Not necessarily.
Mine's opposite. I'm better on I'm right-handed, but I'm left-legged. So along that line, this is not about vision, but he brought it up. We often have we have one leg typically that is your stance leg. Just like your arms, you have one stability arm, and then one agility arm, for, as arguably, those are good words, I think. So stability arm and an agility arm. The stability arm is the one that the baby's gonna be in or the groceries are gonna be in while you unlock the door and you write the note or do whatever. And you're gonna always kind of do that. So usually your dominant arm is gonna be your agility arm that you do complex things with, and the opposite arm is gonna be a little bit stronger and more stable and have better endurance. You're gonna have the same thing with your legs. One leg will be more of a stability leg, and you'll find yourself frequently just resting on that leg because it's your stability leg, it has better endurance, and the other one's your agility leg. Now if you play soccer or some sort of sport like soccer, can't think of any others like it, but you're really gonna have a more dominant one. Or if you've had an injury. So if you had an injury and you say, when I was in middle school, I hurt my ankle, and then my whole life I continued to have ankle problems. That leg is going to be your weaker leg. It's going to be your less used. You're going to automatically use the other one. So even if it's just not pathological, it's just your habit, you're going to still have one that's more stable and one that's more agile, and vice versa. So you may find that in a patient that if their stability leg is the one that they injure, they're going to have problems with stability versus agility and balance. Your agile leg is going to have a little bit better proprioception. Okay, so we did the closed eyes and the touching. Now the little bit of touch makes a difference. So this is for me to remind you when you're doing standardized tests with somebody. If they're doing a test, and let's say, one of the tests involves having them stand and close their eyes. Do you tend to touch their gait belt? Don't do it. If you have to touch their gait belt and you feel like it's not safe for me to have this person do this task without me touching their gait belt, automatically score that you physically had to give them assistance. Now be there, but do not touch them. If you have to touch them, you gotta score it down, because touching them is physical assistance. Well, it's sensory assistance more than physical assistance. All right, you can sit down, sorry. I just thought you guys looked like you needed some action. Okay, so from the visual standpoint, again, you have a peripheral component, your eyeball, and you have a central component, your neurologic system. As we get older, your pupil size gets smaller, so your pupils don't open as far, and therefore they don't let as much light in. So for someone who's getting older, and I can put myself in that category too, my vision is starting to change. I'm fighting it every step of the way, but it's changing no matter what. As you get older, the amount of light you need to function well becomes greater. So some of you guys who, are noticing that I may have something in the kitchen I can't read. I could stick it under the light real close and then I can see it. So we have to let more light in, and our pupil doesn't dilate as much. It also doesn't get small and large as quickly. It takes longer. So if you go from a bright environment to a dark environment, the amount of time it takes for the pupil to dilate is longer, and it doesn't dilate as much. So going from the lobby of a movie theater into the movie theater is going to be a really challenging and dangerous time, because it's going to take longer for that transition to happen. And a new movie theater type environment is not as safe for someone who's got this problem with their eyes. And they're just never going to be able to see as well as someone who's younger and their eyes dilate more and faster. They also have a problem with glare. So a situation that might be glare for someone with a young eye can be significantly glaring for someone with an older eye. So your lens of your eye becomes less opaque, or more opaque and less clear. I said that wrong. So it becomes less clear, more opaque. And so what happens is when you think about how light passes through something, because the lens isn't as clear then it bends. So you have more of a refraction type thing that occurs. So the light goes in, it refracts, and it causes more glare. So a beautiful, well-lit room that's everything shiny and looks just gorgeous to you might be really difficult for someone elderly to see. You've all probably had the experience where you turn a corner, you're going to work, coming home from work, and the glare blinds you. Or you've been skiing and the sun is coming off the snow or something like that. I know we live in Florida, but it might have happened. And that glare just kind of blinds you. That can happen much more frequently and be more disabling to someone who's elderly. There's also decreased contrast sensitivity. So I don't know if these showed up on your book. I didn't actually check this one. So the top one is a green dot on a yellow box. And so that's basically, if you have a yellowing lens, you may not be able to see the green dot at all. It may all look like one thing. But high contrast is much easier to see, so the white on the black is easier to see. This is why we so often recommend, rooms that are designed for older people. A lot of times the facilities I've worked in over the years, especially the nursing homes, the skilled nursing facilities, I always think that why don't they ever ask the medical people's advice when they decorate these places? Because they'll decorate for the public and their family and try to get, because it looks really beautiful and soft tones, but it's really not as effective for people who have a visual impairment, because everything being, nice and monochromatic, which may look soothing, may be very difficult for them to see where's the door. Like these doors would be pretty easy to see. They're dark on a relatively light. But some rooms I'm in, I'm like, this would be a hard room for somebody in an emergency situation to get out because the door is the same color as the wall, and so you can't see it. A lot of times it's a light switch on the wall, a white light switch on a white wall can be hard to see. And so putting that contrast in there can make a difference. The black on white is much easier to see. Decreased accommodation, this is just, your lens becomes like everything else in your body, less flexible. So the ability to go from looking at something close up to looking to something far away it can be harder to do. Have you ever been reading a book for a long period of time? And then you get up and you start walking around and ooh, your vision is all affected. So again, think about being like that all the time, having a difficult time where you really have to focus on something, get it into focus, and then you can see it, and then you go to look at something else. And again, you have to take time to try to focus on that new thing, because everything moves a little bit slower and accommodates a little bit slower. So all these things combined together just cause a little bit of a decreased vision, and that input coming in becomes diminished. And you all see how dependent we are on our vision. And so one thing I'll challenge you to do is, if you were surprised how hard it was to balance with your eyes closed, note that now and start doing exercises with your eyes closed more often. Because you're gonna wanna, before you get too old, and it's really necessary, start really working on that vestibular system and all those reaction times, because if you don't use it, you lose it, right? We've all heard that one before. So you wanna use those systems. So having a well-rounded exercise program will also utilize eyes closed type of exercises. Okay, so we'll build on that idea tomorrow as well. Okay, vision. Low vision is to be diagnosed with low vision, it generally means that even with the best corrective lenses, you can't see. You're typically considered, some people would be considered and classified as legally blind. I've had a lot of people who were classified as legally blind. They could still see somewhat, and we could set up their environment in a way that they could function pretty well, but they're technically, the vision is so impaired that they classify in that range. So these most often are caused by age-related diseases, macular degeneration, basically cataracts or glaucoma or diabetic-related things, retinopathy, and all these different things that you can get can create severe visual deficits. Now, when we think back to the lens in the previous one, this day and age, a lot of people are able to get their vision improved. I know my mom, her vision is actually better than mine now because she had cataracts removed and had new lenses put in. So it's really kind of a turn of events when we're at a restaurant and I can't read the menu and I have to hand it to my mom to read it. So there are things that are reversible and they can improve upon. Low vision typically is when there isn't a treatment, there isn't anything. So we'll talk more about low vision treatment, which is a great area to specialize, especially with the booming elderly population. I don't necessarily see that a lot of people, I got certified in low vision, but it was a very, very long time ago, so I wouldn't consider myself, I wouldn't hang my little shingle out that I'm a low vision specialist, but I've been through some training, and it's very life-changing if you can adjust somebody's environment to help them function and function more safely. Because when you have a visual impairment, it's very isolating. If you have a significant other that helps you get out in the world and then they have a deficit now, or they pass away, all of a sudden their world becomes very small. And if you can't see, are you going to get up and get cardiovascular exercise every day? Probably not. So you're going to be less likely to do a lot of the things. You're certainly not going to be moving your head and eyes around, which is going to challenge your vestibular system every day. So if you don't have them do some of these things on purpose, they will lose all those systems because they sit and they don't move very much. Okay, so moving on and talking about your somatosensory system. So your somatosensory system is basically your skin, the feeling of sensation from touching and feeling things. So joint position sense as well, your proprioceptive feedback, your input from mechanoreceptors. So in your skin, hot, cold, pressure, all that kind of feedback. Your muscles, your ligaments, your tendons, everything that has that stretch sensor versus, all those different things that give you awareness of where your body is in space and what's touching you and what's going on around you. Can give you a sense of limb movement, where your body, as your arms move around, where they are in space, helps with coordination. There's age-related degeneration, so if you don't move or you don't use it, you will lose more. So some of this is based on physical activity on a daily basis, but some of it is just simply as you get older, your nerve conduction velocity decreases, the amount of nerves you have, but some of it is pathological as well. Diabetic-related sensory loss is a very big problem. Smokers, medication, chemotherapy. There's a whole lot of things that will cause pathologic sensory impairment, which will affect the person's ability to sense what's going on around them. I'm going to go into detail about specific things. So we'll talk about peripheral neuropathy, specifically with the feet, because it affects your balance so much. So we'll get into that in a little bit. So back to just review the three big sensory feedback systems, your vestibular, your visual, and your somatosensory. Having slight impairment of all of those can cause your balance to go. It'll basically cause your postural sway to go up. It'll cause you to be just overall less ability to balance, but it'll get worse if you're sedentary. You've got to move more, use them. And the good news is today you'll all get to assess yourselves too and kind of see where am I, and you can come up with a good exercise program. Some people may have temporary reasons why their body isn't balancing as well, but others may have to really take some steps. So when we talk about those sensory feedback systems, there's a few standardized tests that have been developed specifically to measure those types of things. CTSIB. Are you guys familiar with CATS? Some people call it the CATSIB, or you'll be very familiar with it by the end of the day today. What you'll find is the CTSIB is used in many, many, many standardized tests. Modified use of it. So basically the CTSIB test, or the clinical test for sensory interaction and balance, it looks at a variety of situations, and it challenges by trying to eliminate one of your sensory feedback systems. So when you think about that last picture, we've got the vestibular, the visual, and the somatosensory system. To test how one system is doing, you can test it by eliminating the rest of them, which is not easy to do. You can't really, it's very difficult to eliminate somebody's vestibular feedback. It's really hard, but it's easy to eliminate their vision. Close your eyes. So that's why so many of our tests are, you look at them with their eyes open, and then you look at them with their eyes closed. And so when we start thinking about these different tests, and as we go through the standardized tests that you're often using, or if you haven't been, you will be, because I'm going to make a fan of them out of you. When you look at the different systems, so if you look at a modified CATSIB, that means it's something you do with a low-tech equipment, because a true CTSIB test requires high-tech equipment with a computer feedback. And what would happen is, with a computer feedback, you're standing on a force plate, and it's going to give you very sensitive feedback, something that you can't pick up on just by looking at the patient. So it's going to be able to pick up that postural sway and really give you objective data that is harder to come by without that. So There's several companies that make these different force plates that you stand on, and then they give you feedback, and you can watch their little cursor move around, and then it kind of summarizes and gives you higher tech data. That kind of equipment might be super helpful if you treat athletics, if you treat high-level elderly folks, high-level balance impairment, because the better their balance is, but you still think they need help because they're still at risk, it's harder to identify that deficit. So the smaller the deficit, the harder it is to pick up on the problem and quantify it and prove that they would benefit from help. So that's where the high-tech equipment can really come in handy. I wouldn't turn it down if I could get it. A lot of people like you do home health. These big pieces of equipment may not be feasible for you to be able to drag into somebody's home. But if you're in a clinic, especially if you specialize in balance, you very well may have some of this equipment that you're able to use, or you may want it. Now from a modified standpoint, when we think about how we can kind of use these things, the modified CTSIB is you start with a firm surface, eyes open. So you have all your sensory feedback systems. You're standing on a firm surface, so your feet feel the floor. You're getting a lot of feedback. And your eyes are open, and you're in a well-lit room. So you're getting all your feedback. And then you have a firm surface, eyes closed. So you take the same situation, but take vision out of it. And you look at their postural sway and their ability to balance. If they can't balance when they close their eyes, my first thought would be, boy, their vestibular and their somatosensory system is not working well. Because if both of those two systems were working pretty well, they would be able to stand up. Now their postural sway may go up a bit, but they would still be able to maintain a standing position. If they can't, and they're gonna fall over, you're gonna need to explore both their vestibular and their sensation. Now foam surface, eyes open, so what changes? So you put them on a foam surface, and that's gonna it's an attempt to minimize somatosensory feedback. So you put them on foam, therefore their feet aren't getting as good a feedback on the floor. And so it's kind of shifting a bit. So if you put them on a foam surface with their eyes open, and they do poorly, what does that tell you? Well, we've kind of minimized, their eyes are open, so they have vision, and you've just minimized their somatosensory. So now I'm thinking vision isn't 100%, because your vision should kind of tell you a bit how you're doing around, and their vestibular. So you minimize the somatosensory, that's testing more vision and vestibular. And then foam surface with your eyes closed, this is the hardest condition. So they're on a foam surface, you're minimizing somatosensory, you close their eyes. So now if they can't stand up, they fall over like a tree, that's indicative of a vestibular problem. Make sense? Okay, because even when you minimize the two, they should still be able to somewhat function based on that vestibular feedback, enough that they don't fall over. But you'll have people who, you put them in that situation and they'll fall over, and you have to catch them. And that tells you their vestibular system is not enough, it's not effective enough to keep them in that standing position. Now the sensory organization test, this is even more of a high-tech piece of equipment. So basically this is more of think a phone booth type of thing. So the patient is in a chamber of some sort, basically. There's in the front and sides of them, is changing their visual surround. And so instead of like the CTSIB test where they're just on a force plate, they're not only on a force plate, but the force plate moves and they're in a visual surround. So basically what happens is you're really tricking the body. So not only does the floor, if you go and you're swaying backwards, instead of feeling it sway backwards, the floor will match you. So basically it quickly picks up on the way you're swaying and it matches your postural sway on your feet. So it really makes it hard. Think about balancing on a boat. It's the idea of balancing on a boat. Although a boat doesn't match your sway, this matches it. It tries to pull you. So you're really dependent on your vision and your vestibular. Now if you close your eyes, this type of device, the patient will be in a harness because it is such a difficult test that they anticipate likely loss of balance and possible falling. So basically the moving platform is even more intense than the foam because it pulls you. And it really attempts to eliminate somatosensory feedback. It also includes a visual surround in addition to the eyes open and eyes closed. What will happen is if you're like think about going in a fun house where the whole house moves. They're not really that fun, I don't think, but you know what I mean? So you're in this little kind of almost chamber, it's in the front of you and the sides of you. And so when you go to move this way, it goes with you. So not only the floor fools you, but the visual surround fools you, and it really makes your vestibular system have to do its job. Provides false visual and or somatosensory feedback to really test different scenarios in your vestibular system. So I've seen these at trade shows and so forth. I've never worked in a specialty vestibular center, and that's the place I've tended to see these, or when I talk to people, they tend to have these types of devices. And I think like any of us, it's demand, and whether or not this equipment and the expense of the equipment is something you can have. But really cool equipment. I just don't necessarily see it a whole lot in standard facilities, more specialty facilities. But some of you may have access to it.
Well, there's some kind of normative standards of what you're supposed to do when your field's changing with your...
There are, yes, there are normative standards. Now, because I don't use that equipment, I'm probably not going to be your best person to just come up with the idea. But they do have standardized tests that you run on them, and for the computer programs will kind of advise you on treatment as well. So many of the devices these days will allow you to not only assess the patient, but it'll have sort of games and various challenging things that are kind of interesting and fun to use for your therapeutic value, which I think is great. I think that's great. The challenge for me, though, is to throw it into a real life situation too, so that they do it all day long. So whenever I'm seeing somebody, I want to not only challenge them while they're in my care, whether it's in a facility or an outpatient clinic or something, but also try to come up with something they're going to do at home as well that's going to challenge them, because that way they carry over and they're going to challenge their system, because most of these feedback systems, they need to be worked on all day long in order to improve. I shouldn't say all day long, but more than just once a day for half an hour, or 3 times a week for half an hour, if that's what you're getting. So, yeah, a lot of that, we'll keep building on the idea of how to incorporate what you find into a plan of care that's going to be hopefully effective and fun as well, and intriguing enough and interesting enough that the patient complies and also enjoys doing it. Now, fear of falling is a big one to think about as well. It is a predictor. If a patient is afraid they're going to fall, they're probably going to fall. So what will they do? They either will fall, or they'll self-impose, they'll impose self-limitations, and these self-limiting behaviors will cause them to lose more resources and become less functional. So that's a big part of your evaluation as well. There's a number of standardized tests that you can use. I've listed just a few here, and I have them, I have display items on the back table. So those of you who are here in the room, on the back table, those are not for you to take, but they're just here for you to take a look at. If you want them, let me know. Everything except, I think, 3 items back there I got them off the internet. They're things that you can easily get off the internet yourself. And if you go and print them out, then you have unlimited sources of them. Plus, you can not only print them out, but you can also have all the data that you need about them, which is a score of increase of 8 is a clinically meaningful increase in score. Those kinds of things are going to be really helpful to you, because when you do an evaluation, you can give the score that they achieved on the test. You also have your observation of them, and you can say they did poorly on this one and this one, which to me indicates vestibular, and then I do another test. Or this one and this one they did poorly on, which leads me to want to test their sensation in their feet. And so it helps guide what you do next and how you further test, but it also will give you a baseline, which can help you show clinically meaningful improvements, which we're all looking at ways to not get denials, we're looking at ways to justify our care, and we're looking at ways to make the burden of documentation less of a burden, because it's a pain, right? Yeah, so anything you can do to make your documentation time easier, I think is going to be, I'm grateful for it. So that's what a lot of these tests will do for you, and I'll show you how I use them, and hopefully it'll be a benefit to you. So some of the tests that I have, false efficacy scale. It's basically a low functioning, it's designed to look at how do they do in this room, basically. So how do they do in their hospital room? How do they do in their skilled nursing room? So it's really set out for more of a low functioning person, the ability to get in and out of bed, get to and from a bathroom that's right there in the room. So maneuver within a room. But then there's the modified falls efficacy scale, which I presume that somebody had come up with a falls efficacy scale, and then somebody said, you know, this is a great thing, but I want to look at how can they do when they're going outside their house or outside this room. And so they added things like outdoor activities and higher functioning activities, like probably like housekeeping and reaching and bending and those kinds of things. And then there's the activity-specific balance confidence scale, which is the ABC scale. It's very similar to the modified falls efficacy scale, so it looks at indoor and outdoor, within a room, within a house, within a community as well. And the thing that's interesting about these different scales is you don't physically do these things with the patient. So these are not intended to be an observation of the patient moving. They're intended to be to get their opinion. So the way I really like to use these tests, and I actually use them I'd say quite frequently, is when you have somebody where you're doing your typical standardized test, which is telling you how is their balance, and you're looking at their physical capacity to move and their physical function, but then you also want to look at how confident are they, because confidence makes a huge difference. It's not that can they walk, will they walk? Can they get out of bed, but will they get out of bed? You know, so when you ask them questions, you can do both. You can do your regular standardized test, but you can also do a fear standardized assessment, and you can say, this asks things like, well, I have the ABC one here in my book. I'll just read you a few of them. So the activity-specific balance confidence scale, you grade from 0% to 100%. So you basically ask the patient, how confident are you that you can do the following things? I'm not asking you to do them, and I'm not even telling you to ever do these things. I just want to know if you were to have to do them, how confident are you could do them without losing your balance or without falling? So walk around the house, walk up and down stairs, and something like that, if it's up and down stairs, they may tell you, well, I'm 100% sure I could go up the stairs, but I'm only about 70% sure I could go down the stairs. So a lot of people feel more frightened coming down the stairs, typically, but sometimes people have a harder time going up because it's a physically more challenging task. But whatever they give you, you score them the lower score. You might make a note that they qualified it, but you score them with a lower one because you're going to presume that if you go up, you're going to have to come down, and that the combination of things is how safe they are. Bend over and pick up a slipper from the front of a closet door. So you take a kind of a piece out of the bird balance scale, but you don't actually have to have them do it. You just ask, how confident are you could do it? You might do this first if you all of a sudden see you have a really scaredy cat. You know what I mean? You know those people where you meet? What are we doing? Why are you doing that? What are we going to do? You know, they're very, very nervous and scared. You might start with a confidence scale because before you build their confidence, which sometimes in your first assessment, just having them go through a standardized test, you may all of a sudden build their confidence. So you kind of want to capture that real fraidy cat moment before they, you know, that might help you by seeing how scared really are they, and then you've already started treating them during your assessment. So bend over, pick up a slipper, reach for a small can off a shelf at eye level, stand on your tippy toes, reach for something over your head, stand on a chair and reach for something. That's when I often qualify. I would never want you to do that, but if you were to have to get on that chair and reach up to get something, could you do it? You know, you picture somebody trying to stop their fire alarm from chirping or something like that. Sweep the floor, walk outside the house to a car parked in the driveway, get in and out of your car, walk across a parking lot to the mall, walk up or down a ramp, walk in a crowded mall where people walk past you rapidly. One of my biggest problems with this is I usually tell them I really just need a yes or no. I need a number, because this will take 5 hours with a lot of your patients because they want to discuss every one of them. I'll just say, I really need you to make this as accurate as possible. I just need a number. How confident are you? In order to make the test go reasonably quickly. Bumped into by people as you walk through the mall. Step on or off an escalator while you hold on the rail. Step on or off an escalator while you're holding parcels that you cannot hold onto the rail. And walk outside on icy sidewalks. I very often quantify that one as in a wet, you know, you're walking through an area where the wet tile or a wet rainy day where you're walking on a surface that's a little slip. If they say, I've always lived in Florida and I never walk on ice, but many people are snowbirds and they've walked on ice, and they can imagine what it would be like. So basically, that's the idea. So something that can be really telling about a patient is if you did this with them and they said, you know, say one of the questions which was pick up something off the floor, and they gave themselves, I don't know, a 30%, or they were really not confident they could do it. And then you follow up and you do a bird balance scale, or one of those that involves reaching down, because many of our tests will involve that same task and they actually do it. Well, right away you can score them, but after you're done with your test, you can reflect on it and tell them, you know, you really didn't think you could do that, but look, you did, and look how well you did it. So your therapy has already begun, because sometimes it's not enough to restore the ability to actually do it, but their ability to feel confident as they do it, so that they, you know, so they continue to do it. You know what I mean? Because if you don't think you can do it, or you're afraid to do it, you're going to limit yourself. Okay, so fear can be a wonderful thing to measure, and then use it as one of your standardized tests, because there are statistics that show low confidence means they will fall. They're at a higher risk for falls. So that information is available. You can document it. It can be another one of your interventions. Attentional demands. You know, this is another one. It's a little bit challenging to quantify, but there are various tests to use. And it's something we definitely need to be looking at. Basically, the idea is you only have so much ability to attend to things. So this picture, I don't know who that is. That's just somebody I found on the internet who was doing a lot at once. Talking on the phone, going through a door, holding a bag, you know, probably noises going on around them. Would have been better if we had like 5 kids also surrounding her. But, you know, the idea that you want to do multitasking, it becomes more difficult if you don't have as good attentional demands. So that's something you want to look at with your patients is if you're evaluating them in a quiet environment, nothing else going on, and you're evaluating individual tasks, you might get a false sense of positive. If this is someone who's going to hopefully go back to a busy facility, busy household, community, you're going to need them to be able to attend to multiple things at once in order to be safe. So just because they can do something in their room doesn't mean they're going to be able to do it out in the hall where there's a lot of hustle and bustle going on. So decreased attentional resources increases fall risk. So when you test these things, you know, various research studies have shown that people will prioritize different tasks. So the typical measurement that you will use is you'll have them do some sort of dual task. Stops walking when talking is an actual test. So there is a standardized test. It's called the stops walking when talking test. And we do it all the time, don't we? Do you have a patient that you work with that, you know, have you ever had somebody come back and you're about to go evaluate somebody and they say, okay, are you going to see Mrs. Smith? Try not to ask any questions. You'll never get done. Because they're the person that you're doing something, and every time you ask a question, they stop everything and they answer your question. Well, some of that could just be respect, because some people think it's rude to not stop and look at you when they talk to you. But you can instruct them, I want you to keep moving and don't stop. I say that constantly. That's when you think back in your day, one of the things you say over 100 times a day, it's don't stop, keep going. Because I'm talking to a patient and they automatically, you know, if they're on some sort of an elliptical or a new step or whatever they're doing, I'll say, no, don't stop, keep going as I'm asking the questions. And you can actually measure whatever you're using, their quality of movement, whether it's the RPMs on the equipment they're using, whether it's the performance that they're doing or the accuracy of the answering question are both ways to measure. So going in and trying to quantify it, you put them in a dual task or a multitask situation. And to do it for a stops walking when talking test, it would be you have them walk a distance, and then you have them walk that, and then you also ask them certain questions, and then you have them do together. You have them walk while answering questions. A typical one would be the timed up and go and the timed up and go with a dual task. And so basically the timed up and go, you have them stand up, you walk 3 meters, approximately 10 feet, you have them walk, turn around, come back, sit down. So you do that physical activity, and then have them perform a cognitive task, which is usually count backwards from some random number by 3s. Hard to do. A lot of my patients can't do it, and to be honest, I've done it with people before, and I'm not sure if they were accurate or not because I couldn't remember. So it helps if you videotape your session, because sometimes I'll realize I wasn't paying enough attention and I'm not sure if all their numbers were accurate. So if they're counting backwards by 3s And let's say you do the test when they're sitting stationary in a non-challenging environment, you may start from 99, and then you repeat the test at the same time. So you say, now we're going to combine the two. I want you to get up. When I say go, you're going to get up, you're going to walk same way, turn around, come back and sit down, but I want you to immediately start doing that counting test. But this time I want you to start from 82. You know, you give them maybe a different number in order to make sure it's not repetitive, and then they go. But sometimes I have to modify the cognitive task because they can't even do it at all while sitting there. So a lot of times I'll refer to speech therapy, and I'll say, so I need a dual cognitive task with the timed up and go, and there's no way they're going to do the typical, what's a good task. So you may do that so that you can get the measurement, and then also come up with an intervention that you can do as well that you can measure again later. Some people will just say, absolutely couldn't do it, could not do the cognitive task. I'm like, well, if it's only a measure of their cognition and it doesn't really help you figure out what you're looking at, which is their ability to function and physically move while performing a cognitive task, it doesn't necessarily help your plan of care. So a lot of times I'm looking for something that is minimally challenging while sitting and not moving. And that becomes more challenging when they get up and do the physical task. Gives you a better picture. And then I've had people who are pretty high functioning, and we do 3 tasks, so we multitask. So it might be the same idea. We're going to have you do the cognitive task with the physical task, and this time you're going to carry a cup of water that's filled pretty close to the rim. Or you're going to carry a cotton ball on a spoon or whatever. You give them an additional task to make it more challenging, and it might be very appropriate given the fact that this person's going to go back to work, or this person's going to be serving hot soup to people in a restaurant, or whatever, you know. So there may be a reasonable expectation that they're going to be able to perform such a high multitask, and that's where you put it in your documentation that it's supported. Okay, so attentional demands is a great thing to be looking at, and then it's something you can include in your programs. How are we doing on time? Let's do just a little bit more, and then we'll take a break. Okay, so let's talk about some individual medical complications. With all the things we've talked about so far and the resources, you can think about various diagnoses and what you automatically know you're going to have to look at. Like Parkinson's, I mean, when you think about Parkinson's disease, clearly reaction time is typically something you consider. The ability to react quickly and, you know, range of motion, postural sway is often going to be significantly increased, but we also have Parkinson's where it's very mild, and then you have severe Parkinson's. And so just thinking automatically when you go into evals, based on knowledge that you already have, additional tests that you're going to probably need to do, and it'll also help you be reasonable with your goal writing, and what are the expectations that you can reverse any of these things. Diabetes. I mean, diabetes is such a huge widespread problem these days. Having diabetes definitely leads me to really want to check their sensation, especially in their feet. Their range of motion in their ankles is typically, by the time they get diagnosed, most people already have limited range of motion in their ankle and forefoot, and they often have decreased sensation in the plantar surface of their foot. Those are severely going to impact your ability to walk and balance. But also it leads you to wonder about their other resources like their vision. It's not uncommon for them to have vision loss or impairment, and so you're going to want to look at that as well. Arthritis, I mean, who doesn't have arthritis? But for me, to me, when I have somebody with arthritic changes, it always leads me to wonder about pain, self-limiting behavior, unnecessary self-limiting behavior, because a lot of people, for whatever reason, what do they think they should do when they're hurting? Rest. I mean, so many people think I need to rest because I'm in pain, and you have to educate that the more you rest, the more you're going to hurt, and the less you're going to be able to do. You got to move. And so you go through exercises with them and show them how they move better and with more ease and with less pain, and do joint mobilization and things like that to point out and show immediately the decrease in pain and how they can move. But it also will help you look at how to test and ask about fear. You know, definitely if I have somebody who you're reading on their chart that they have one of their first complaints is painful arthritis, before I do any physical testing and change their beliefs, I'm going to right away measure their fear, because A lot of times they have unnecessary levels of fear, and then you can identify that and hopefully address it by turning it around and saying, well, look how good you did. You think you can't do these things, but you actually can, and it's going to make you feel better. CVA, I mean, with a CVA, you're automatically going to think everything could be missing, but maybe on half. It could be half of everything. So strength, range of motion, all of those things. But again, it leads you to kind of look very specifically at all of those things and look at what part of their brain was damaged. Nutritional compromise, I mean, there's so many things. I'm not a dietitian. We have a new wonderful dietitian at work who's been so great at looking at these kinds of things. So sometimes it's frustrating to me because I have more questions than answers, and I'm very curious, and I don't have the data I need to know how is their nutrition, because many patients will tell you, oh, no, I got a great diet, you know. But it's hard for you to just know by talking to somebody. But I will ask them, what type of eating habits do you have? What's your favorite food? What's something you eat every day? What's something you eat at least 3 times a week? It's going to help you know if it's, you know, potato chips versus spinach. You know what I mean? It's going to automatically lead you. Or if they have religious beliefs that cause them to eat a limited diet or certain things, or they have they're vegetarian, or they just don't like, they have poor taste or poor smell. All of those things are going to be indicative, because no matter how hard you work, if somebody has severely low protein or they have severely limited, you know, hydration levels, they're not going to progress in therapy. So it could be that if it's a home health or an outpatient, you refer them to somebody to get help. Or if it's in an inpatient setting, you can really drive home the idea that they need a lot of attention and work with nursing and dietary to get that problem addressed. Recent hospitalization or illness, that's very broad, but whatever led them to you. Sprained ankle, broken arm, whatever type of injury they may have had that leads them to you, you're right away going to think, okay, what do I need to be looking at specifically based on what just happened to them? And fear, if it was a fall, I mean, based on this name of this course, it's very likely it could have been a fall. If it was a fall, start with a fear test if they're cognitive, if they can answer those questions, because right away you want to see how impacted are they by the post-trauma of the fall. And a lot of them will automatically be like, I'm never doing that again, and they were walking in the grocery store. You know, well, certainly I want you back walking again. If they were dancing, maybe they were drunk, the next time they dance, they won't be drunk again, but they'll get them dancing again in a good way. So basically, it can help you set goals. If you identify a previous behavior that they were doing and they now say, I'm never doing that again, and you identify some fears that you think they're afraid and therefore they're not going to do it, but this is a goal I want them to achieve and I want them to feel confident when they do it, then you can, again, it can help you guide your goals. And I'll say that not only the patient will do it, and they'll do it with a certain score and a certain level of performance, but they will also be confident when they do it. They will state a confidence level of 100% or whatever you deem is appropriate. Hypotension, that's something that so many of our patients have, and it may be an ongoing thing or it could be just temporary because they were sick and they're on pain meds right now. But we'll come back to the basically orthostasis kind of problem. Why don't we take a little break? 10 minutes sound good? Okay, let's take a 10-minute break. So according to my clock, it's 10 till 10, so we'll resume at 10. Let's talk for a minute about peripheral neuropathy. This is one of the things that often frustrates me when it goes unnoticed for too long. Anybody who treats people with diabetes, or really anybody in a healthcare environment, should be looking at diabetes, blood sugar levels. They should be looking at sensory feedback systems, and we should be identifying lower leg issues that are going on, because when we identify them early, they're much easier to treat, and you know, once you have a significant neuropathy, their chances of staying a high-functioning adult are not that good. So the sooner we can catch it and hopefully prevent further decline, the better. So peripheral neuropathy can be sensory, it can be motor, and it can be autonomic, or a combination of all three. So when you think about sensory neuropathy, the plantar surface of your foot has a very large vascular bed and a very large sensory bed. High sensation, lots of feedback. which is why you have that great ankle strategy. It's part of why you have a great ankle strategy, is because you feel so much going through your feet, and you feel even the slightest shift forward, backwards, and when you're on one foot, side to side. So to test somebody for sensory neuropathy, you can do a preliminary test just literally by touching their foot. You know, you can test their sensation. But using Weinstein monofilaments, specifically the 10 gram is the one that is more of an objective measure that you can use. We typically, if you're measuring, you can go on, there's actually a program, and I should have gone on and checked it. I can do that on the break, but there's a program called a LEAP program, L-E-A-P. There's a lot of different LEAP programs when you go to look for it, but look for limb amputation prevention. So you can put in LEAP program, amputation prevention, because it stands for lower extremity amputation prevention. And that program used to offer a lot of free education products, and you could also order free monofilaments. And I think it was about 10 or a dozen. I haven't gone on there and checked, because from time to time, people will text me and say, or email me and say, I tried to get the monofilaments and they were on back order, and I'll say, sorry, you're gonna have to buy them. So, because you can buy monofilaments, but if you go on that LEAP program, the whole idea is to look at the high risk for amputation with your diabetic population and the peripheral neuropathy, and a lot of educational tools that you can print out and give your patient. Also educational tools for yourself to help you be aware of the cause and the effect of it. But basically, Weinstein monofilaments, they're basically just 10 gram. I've got a couple in the back of the room, so for this afternoon when we do lab, that's one of the things we can review is how to test. On the various websites, excuse me, they have like a picture of the bottom of a foot, and it'll have all these little circles, and you test each of those areas. So the toe beds, the places on the forefoot and the heel, and you basically, it's just a monofilament. Think of it as a thick fishing line, piece of fishing line. You basically put it against that spot until it bends, and it takes 10 grams of pressure to bend it. And so you put it on each spot, you push till it bends. If they feel it, you put down, yes, they felt it. If they didn't feel it, negative, they did not feel it, and you go to all those different areas. And then there's a lot of different research to back up the whole idea that if you don't have sensation of the 10 grams of pressure, that you have a lack of protective sensation, and that puts somebody at significant risk. Now, if they have a slight decrease, but it's not, maybe on a couple of their toes or a certain area, then you can educate. You can also look at why and talk to them about whether it's their blood sugar. There are other reasons why you can have peripheral neuropathy, but the most common reason in our society is diabetes. So you can talk to them and drive home the idea. It's not enough to be just a great therapist anymore. You have to be a psychologist on top of it. Do you agree? Yeah, so based on what you see with the patient, whether you think you need to do scare tactics, or, a lot of times I'll just say, what was your blood sugar? What's your average blood sugar in the morning? What's your blood sugar today? When they look at you like, oh, they don't know, they're not taking it seriously. So you can kind of gauge how much education or that they need. You could pull out pictures of amputees, or introduce them to an amputee who looks at you and says, I wish I'd listened 5 years ago, those folks. But regardless, figure out how you educate them as to how important it is, because many people who have peripheral neuropathy will end up with an amputation. They'll end up with a non-healing wound, and then they'll end up with an amputation. Now, vibration testing is also something you can use. You basically just hit a tuning fork and you put it on the different bony prominences to see if they have that sensation. I don't do that one as much, but I definitely do a lot of the monofilament testing to make sure that they have the protective sensation, and then you educate. Motor neuropathy. So motor neuropathy occurs, all of these things occur in sort of a stocking formation, so you lose it distally first. So sensation, they tend to lose it on the plantar surface of their toes first, and then it progresses up the foot and up the leg. Same with motor. So what happens is you could have a pretty severe motor neuropathy, and it only affects your intrinsics of your foot. And it can be hard to notice because they can still dorsiflex and plantar flex. Their calf muscles will often still work, but they've lost a lot of their intrinsic motor activity. And what happens then is they do lose the stability of their foot, they lose some of the ankle strategy that you would have, with the toe activity and the movement, especially medial lateral. And they also lose the physical nature of their foot, and their toes start to curl up. So if you have a intrinsic motor neuropathy, their toes tend to be, instead of nice and flat and your foot looks like it should, the toes curl up. And so they develop this, they're at risk for wounds is one thing, because their toes now their forefoot is deeper from top to bottom, but it's shorter from front to back. And when you ask somebody, what size shoe do you wear? Well, I used to be a size 9 and now I'm an 8. That right away tells you, they can't feel their foot on their shoe on their foot, and they need a tighter shoe to kind of feel it. They don't feel it. They don't feel their toes hitting the end of the shoe. And normal shoes don't fit them anymore, because a normal shoe is designed for, not anybody's exactly normal, that's kind of but your typical off-the-shelf shoe is not going to fit them well. So they're going to need extra depth shoes with more space in the toe box from top to bottom. They're typically going to need to be able to put a specialized insert in there. And so they're going to need shoes that will accommodate that. But motor neuropathy, so you start to have the atrophy of the intrinsic, so the foot changes, just like atrophy anywhere in your body. The way your foot looks and moves, it's going to change, the shape of it. You can also get fat pad migration. You have on the plantar surface of your foot, over your metatarsal head, so you have a very thick fat pad. We're all pretty aware of the heel fat pad. The fat pad of the heel is very, very supportive, and it bears a tremendous amount of weight, especially for that heel strike. But you also have a fat pad over your metatarsal heads. And what can happen is that will migrate, because as the foot starts to change, it migrates, and a lot of times it ends up in the instep of the foot, which causes you, if you look at the foot from the side, you usually have this arch in the foot. Well, a lot of times that fat pad has moved, so you have these toes that are curled up, so it's deeper here, and then you have a fat pad that's migrated, so it's real skinny in the forefoot, and then you have an instep that's it's altered, because maybe part of the instep is getting a fat pad there. The problem is your shoes wouldn't feel good. If you were wearing typical shoes, they usually wouldn't feel good, and when you get shoes that don't fit you right and you don't feel good, you stop wearing them, but their sensation is usually altered, so they don't realize that they're getting pressure where they don't normally, and then if they walk, and they walk a lot, or they stand a lot, especially for their job or something like that, they can start getting repetitive problems, and they build up abnormal calluses. They start building up these thick, waxy calluses, and those waxy calluses can actually become external sources of pressure. Like I taped a nickel to the bottom of your foot and you walk around on it all day long. So again, it's just this event that happens, but it doesn't happen overnight. These changes happen over years of time, and it's lots of opportunities for people to notice it and educate. Because a lot of times the education doesn't happen until they're going in for an amputation, or they have a non-healing wound that's chronic and difficult to heal. Because once they get a wound, then we got to talk about the autonomic neuropathy. So autonomic neuropathy is all those things that you can't just make happen. I can't look at my foot and say, sweat. I can't make my foot just start sweating, and I can't make it have vasodilation or any of those things. So those automatic things, like you stubbed your toe or you squeezed your toe and blood flow was diminished, and then you let it go and the blood flow should come back in. Your ability to react to hot and cold environments is autonomic. Your ability to establish an inflammatory response related to some sort of a trauma is impaired. And so many times these folks whose skin is starting to become impaired, their bones are becoming impaired, their body isn't able to respond and do all those automatic things that they should do. So again, that's where the autonomic problems come in, and they end up developing wounds and deformity. So they need ongoing foot care. And I spend enough time on this because I think many times we're seeing these folks, and if nobody's educated them, you gotta you gotta definitely make them aware that these are problems. So this is somebody, once you get severe deformity, like something like this, that's usually called Charcot deformity, C-H-A-R-O-T. So Charcot deformity is basically the idea of the deformity, the physical changes, and those involve bony deformations as well. So you can see this person's fat pad, which would normally be here, has migrated, and the bones have changed. And so this person doesn't have any pain, but has abnormal forces and high pressure in areas where, somebody who isn't medical and doesn't know about this, and you tell them you need really good shoes, get yourself some really good shoes. If you just tell somebody that, what are they gonna do? They're probably gonna get really expensive that are gonna be high arches and very good supportive shoes, because a lot of people think good shoes require a good solid arch. Agreed? Many times? I mean, that's often. So this person, the last thing on earth they need is a nice solid arch because they don't have an arch. So they're actually doing themselves the worst. And the toes being curled over is, again, they need good ongoing foot care. Check between the toes and educate them that you or someone else needs to be checking between your toes every day. Because if you wake up and put your shoe on and there's something stuck between your toes, it's annoying and you feel it and you get it out. They don't know. So they've got stuff in there that's wet and yucky and stinky, and they don't know it because they can't feel it. So that's an idea of neuropathy. This is someone else with more of a Charcot deformity. So the fat pad has migrated, leaving these metatarsal heads unprotected. So there's this bony, you feel the bottom of their feet, you just feel the bones there. And so the bony prominences are hitting the floor, and they often also have a lack of dorsiflexion. So because many times they have poor range of motion and poor sensation and poor physical activity levels, they lack dorsiflexion, so there's increased forces on the forefoot, and they still walk, but they get these pressure areas. So the curled toes, the deformity, and the abnormal calluses are really indicative of it. So if you encounter someone like this, hopefully it's not like that. Those are the people you're going to see in the wound care, specialty wound care centers, and they're getting total contact casting, or boots, or whatever, or non-weight bearing, or amputations. Many, many times they end up with an amputation. The key is for people who see them before they get a wound to identify it, or the people who are just starting to have some impairment of sensation, to kind of show them pictures like that and say, this is the future. If you don't make changes now, this is what will come, and that you've got to be careful. So just drive home the idea, because you can't fix it. A lot of them want you to fix it, but you can't. They've got to make changes. Okay, so that's something that's a very individual thing. This is something, orthostatic hypotension is something you're probably going to see on a lot of people. Anybody who jumps up quickly is going to get some orthostasis. Anybody who gets, if you're in bed, laying down, having a nice dream, and you realize you're late for work, and you come flying out of that bed, pretty much anybody can experience a moment of, you jump up and go run across the room, and like, oh boy, give me a second, and then you're good to go. So you very quickly, your body's capable of correcting it. But the idea is when you move from a more dependent position to a more upright position, gravity takes over. You know, you're basically a ball of fluid. You know, your blood and all the liquids in you is going to want to go with gravity, and your body has to correct it and keep it up in your brain. So it's kind of crazy that the most important organ in our body is the highest up in your body. So basically it's very gravity dependent, and if the blood runs down, this important organ in your head is not getting enough blood flow to it, and all of a sudden everything goes wrong. So basically postural hypotension, orthostasis, orthostatic hypotension, those are all things that you'll see in the documentation, is when your blood doesn't stay in your brain when you sit up enough and you have the symptoms of it. Why does this happen? Well, gravity. But you know, when you think about what happens when you sit up, when you jump up, you have a baroreceptor response. So basically the baroreceptors throughout your body will sense minute changes in blood pressure somewhere in your body. And so when you sit up and you're healthy, your body automatically senses that there's not enough blood pressure up in your head and your upper body. And so automatically vasoconstriction of all your periphery will happen, and your heart will beat harder and faster. And so your body's response will automatically correct it and cause constriction. And you know, as you get older, that can change. And so as you get older, that baroreceptor response is just slower to happen, and so they have to transition slower. Quick movements are going to result in some lightheadedness, dizziness, possible fainting. And then the cardiac response is often diminished. Their heart doesn't beat hard and fast like it would for you when you jump up. It could be deconditioning, you're just not used to it, and you've got to slowly condition them. It could be medication related. I mean, when you think of anybody who's on blood pressure medication, blood pressure lowering medication, and you think how those medications work, a lot of times they limit your ability to constrict and bring that blood pressure up. And so they're going to be either always at risk and they have to just learn how to transition more slowly, or you can discuss when the benefit risk is too much, when the benefit they're getting from the blood pressure medication is not worth it. And that's where you have a conversation with a doctor and you say, you know, they're also on anticoagulants because they had a DVT, or, you know, all my patients are on anticoagulants. Any spinal cord injured person or stroke patient, you know, they're pretty much all going to be on anticoagulants. But when the risk of falling and having another injury, or they're severely osteoporotic, you know, they have severe osteoporosis or something like that, when you think, boy, at this point we need to sit down and have a conversation because the risk of taking this medication is probably higher than the benefit it's offering them. So that's where the multi-heads having a conversation together can decide what's the best for the patient. So that's where collaboration with the rest of the medical team is important. Yes, sir.
So you're saying people on high blood pressure medicines may be lowering their blood pressure too much, and therefore you need to address.
Yes, very, very likely it is. It also could be limiting their ability to respond quickly. So even though it'll still allow their body, when you go from laying down to sitting up or laying down to standing up, it may slow that transition and it'll diminish your ability to get up quickly. And so the medication itself could cause you. Other medications that are super common that do that are pain meds. I mean, especially our opiates, you know, those are smooth muscle relaxers. And when you think about what is a smooth muscle in our body, well, many, many things, but, you know, definitely your blood vessels are. And so people who are on pain medications, especially our post-surgical people, they may have many factors going on. They're dehydrated, they're deconditioned, they're taking medications they're not accustomed to taking, which multiple meds can cause you to have a difficulty transitioning from, you know, it can cause orthostasis. And so those things, that's where we can work with the team on maybe getting them off some of those medications. A lot of times patients don't need as many meds as they're taking, depending on the setting you work in. They started taking this much med when they were super acute, and they did need them, but now they're moving through the rehab process, and they don't realize they should stop taking and start quickly weaning off of them. I think more people are aware now than they used to be, and I think because of the publicity about opiates, I do think people are a little bit more reasonable in getting off of them, but there are some still that are like terrified of hurting. They're afraid of pain. Nobody wants to hurt, but illness or disease as well. So various illnesses or diseases will cause you to have low blood pressure. I know with spinal cord injury, they typically have quite low blood pressure. It's not uncommon for our folks to be like 90 over 50. I mean, sometimes that's just their resting blood pressure. And so we have to work with them and find out what is their baseline going to be, because you're going to need to know. Everybody should know what their baseline blood pressure is. That way, if they're not well, you know if your blood pressure is higher or lower than normal. Okay, so tomorrow we'll go into a little more detail about treatment, but it is important for you to be thinking about what you can do, you know, things like hydration and compression stockings and maybe slow transitions for now, but we also may consult with the rest of the medical team on other things that could be happening. Along those lines of medications, I mean, this is something that can be very frustrating for us as clinicians when we know that there's something going on and we maybe are concerned, but we can't recommend somebody stop taking their medicine. I think for the most part, we can advise them to speak to someone about it, maybe refer them to their pharmacy, their physician, but I think we all agree that for me to say you can't keep taking this medicine is not appropriate for me. I can't do that. But I can advise and I can make phone calls to their physician. I'm pretty lucky. I have physicians that I work with that are just wonderful. I have their numbers on my cell phone. I mean, wherever you ever work with, that's the case. I mean, I literally can text and call our physicians. So I'm very, very fortunate. It hasn't always been that way, and I can't call them all. But there's certain ones that are wonderful, and we can have a conversation. They actually listen. So that's helpful. I do have some information in the back of the room. There's a few little tools you can use. So there are some, you know, documents that talk about polypharmacy. I mean, polypharmacy, that diagnosis is just 4 or more meds, technically indicates polypharmacy. Any of you guys work in SNF, skilled nursing? A lot of you? Yeah. Are any of your patients on 4 or more meds? I mean, are all of them? I'll never forget, because when I first, you know, I worked in skilled nursing facilities for a long time, and I remember when I was first learning about the MDS, the minimum data set, and I remember looking at different, like, quality indicators, and you look at, you know, and you look at, what was it, 9 or more meds? I think it's either 8 or more or 9 or more. I think it's 9 or more meds is the quality indicator, and I'm thinking, I was surprised, like, who in the world is on 9 or more meds? Turns out most of them are, you know? So a lot of people are on multiple medications. And so I know those of you who do home health in the Oasis, if you open the case, you have to list all their meds, correct? Yeah. And I think most people have a tool that will give them feedback where you can look the common side effects from those meds, and many of those programs will spit out to you concerns that you ought to have, like medication interactions and things like that. So I think more of us have tools that used to only be available to pharmacists, and now they're available to everybody. So it can help alert you to something, and hopefully you can get some of those things changed, because many of the patients not only don't even know what the medication is they're taking or the side effects, but they don't keep track of them very well either. And you know, I mean, I've been through this with my own family, trying to figure out how to get them to manage their own medicine safely. It's challenging, but there is a document called the Beers criteria, BEERS, and it's the author that came up with it, and it's a nice tool to have, and there's tools wrapped sort of that come along with it. It's just a list of medications that probably your people over age of 65 should not be taking, and why, and alternatives. And it'll say, here's some things to look at. It'll give you something to say, this person is on 3 meds that are listed on the Beers criteria. Write a note to the doctor, just say, you know, and maybe they're on 3 different doctors who have 3 different doctors have ordered those meds, and nobody's really analyzed, because everybody's busy. But it might give you a tool to be able to just say, you know, FYI, I'm concerned, could we have a discussion about this? But some of the things, anything that's like antipsychotic, pros and cons about antipsychotics, I mean, we find them often very, very helpful with our brain injury clients. But I think they're probably in the common population overutilized. And so there may be alternatives that you can offer that you can say, here, we're going to work on this, and that maybe help decrease the person's need for those things. But that's for, again, as a team, we work on the antidepressants. I mean, same idea, very, very often prescribed to people by a general practitioner who isn't really measuring and following up on their depression. And so, again, it might be an area where they've been taking it for a long time. Maybe they kind of did benefit from it at a certain time because their loved one died or they had an incident or an accident, but maybe they don't need it anymore. And it's possible one of those things that just had no end date on it, and it's time for an end date to be considered. Anti-anxiety medicine, same exact idea. It's sometimes people just don't have an end date on these meds, and you want to always evaluate, because every pill has a price. Everyone has a side effect. Some of them are well worth it, but some of them, they may be more worth it, but after time goes by, nobody thinks to say, well, gosh, I may not need this anymore. Antihypertensive, these are super common and often very, very medically necessary. It's just, again, as changes occur, you might be the sort of person to just bring awareness to it, take a look at it. Even things like antihistamines, the over-the-counter meds, can have an effect. So I never used to have allergies. I mean, I used to be so fortunate, but I'm not gonna let you know I'm not lucky anymore, because I've had them terribly this last 2 years. And I realized firsthand how these medications affect people, so I have a new awareness of it. But yeah, anything that can be an antihistamine, it can have a sedative effect, it can have it can affect you in many ways. Everybody's different. Anything sedative, hypnotic, people are taking in sleep aids, can also cause significant impairment. When are you at the most risk? I mean, we have somebody who takes a sleep aid and they go to bed, and then one of the worst things in the middle of the night is to get up and go to the bathroom, and there's so many hazards around them. So again, things to think about. Anticonvulsants, I mean, we could go down the list. Every single pill can have a concern, and there's tools out there for us that can help you if you want to just sort of raise awareness. And just being on 4 or more meds can diagnose it. Somewhere, it's been quite a few years now, but I remember reading an article that said polypharmacy was the #1 diagnosis in emergency rooms in the country. Now, I don't know that it is today, but there was a period of time where I remember reading this article about it, and I was like, okay. But I was diagnosed with polypharmacy once because I took too much cold medicine. Not too much, it was the amount you're supposed to take on the thing, but too much for me. And so technically, I had an adverse reaction, and I was not functioning. I was feeling faint and just really not well. but anybody can experience it based on the combined effect of more than one med and how they affect you in general. So everybody's not the same. And I've had so many people who've said, well, I've been taking that for 5 years, never had a problem. Well, you're getting older, your kidneys are changing, your liver is changing, your hydration level may have changed, and your reaction to the meds changes over time. Another thing that you want to assess is environmental issues. Those of you who do home health you're going to probably have the most to do this on a daily basis is to identify hazards around them. Those of us in a facility, we need to always be looking at this because falls that could have been prevented is a real problem liability-wise if you guys are not watching for these things. But looking for trip hazards, my hat is off to you guys that do home health because I'm sure it's quite challenging. Just dealing with the few people that I deal with, like my mother. Sorry, Mom, if you're watching this. I don't think she is, but just trying to get the environment the way it's safe, but they don't always want to because it's not pretty. And I really like my rugs in my bathroom, and I love these rolly chairs, and I love this little spinning rocky chair, and things that are really horrible and unsafe to be in. So the challenge is to educate. But things that they could trip over, all these things, a lot of it seems like common sense, but what you think is common sense is not. You are not common. You are way, way more intelligent on these subjects than the average person around you. So just because you see something and you understand it, the majority of people around you will not. My husband set this up this morning and he didn't notice that's a trip hazard. This wire here is a trip hazard. Things being left out, all of us are aware of things that your average person will not be. So assume people that you're treating or their loved ones don't know any of this stuff. Talk to them respectfully, but explain to them and gauge their feedback to you and see if they understand it, and then you know how much further you need to explain. Animals, that's a common problem that you may run into. Animals can be a wonderful thing from a motivation standpoint and getting them up and moving and get them out of the house. But on the other hand, it can be a real hazard to a patient. So again, benefit risk, you gotta look at those things. Like while you're doing your exercises, give your little Fido a bone in this crate while you do these things, because you're gonna be putting yourself at risk doing your exercises. You don't need Fido jumping on you while you're doing it. Improper furniture is a big problem because some of these things that you want them to correct, they don't have the resources financially to quickly correct them. So it might be I shove it into a corner, or, from my standpoint, it's a home assessment. That's where we go and we do home assessments on most people, but it's not always reasonable to do. But when you see these things that can't be quickly corrected, try to find an alternative. Like I found one chair in the house that you can use. You can use this one, but none of the others. Improper lighting problems, poor lighting or glare, and they just need some shears over the windows or something simple. Poorly fitted or maintained assistive devices. I mean, this is where we can come in. Is it still happening, those of you guys in a SNF, when somebody goes home and they need a rolling walker or they need a wheelchair or something like that, do you get it and they go home with the one that they had? Or do they have it at home at some point? Is it still that they go home and somebody delivers it, some DME equipment delivers it to their home? I have some
Usually
beds,
they
some
get
homes.
it in the facility and take it home.
They get it to the facility, thank goodness. Because I remember, I've been in different scenarios where some people just automatically, they can't have it, but most DME companies will work with you and will get it to you prior to discharge so that you can set it up for them. Because you have somebody who, if they go home and they don't have the things they need, if you can send them home with some of your equipment and then it gets returned after their first home health visit, when the home health agency comes in and they can use the equipment the first time, make sure it's right for them, set up for them, and not still in the wrapper with as short as it'll go, and they're walking around on a walker that's like 2 feet too short for them. But when you look at statistics, the most dangerous time in a patient's life is the first 24 hours in a new environment. The least we can do is try to look at the obvious transition things and make it as simple as possible and safe as possible. I know we have a lot of patients where we want the first home health visit set up and clarified, and we know who's coming and when they're coming before we will let that patient leave, because it's life and death critical that this person get their home visit. Because a lot of times you go home with the order for home health and they don't actually get a home health visit for what, days? sometimes days. And in some cases, it needs to be within hours, just to make sure they can get in their bed that night. Or, certainly within 24, 48 hours if they need to go to the bathroom, and you need someone to be there to make sure it's safe. So you can do a home assessment, but it's very different when they're actually there and there's no one there to help them. So things that you can do, anything you can do to help those transitions happen. And the first 24 hours in your own building, when someone admits to your building or to your care, to make sure that you guys have a good transition method, that you do your really good assessment right away, and that we pay special attention to their environment, their bathroom, their toileting ability, their ability to get their needs met, their immediate needs, and any kind of equipment that they're using that they can use it safely. As improper devices that we've provided them becomes a liability on our part. Improper footwear, this is also a big problem that you might have. Little ladies bring to mind where they just simply want to wear their little flip-flops or their sandals or their cute high-heeled shoes or something, and explain how cute are they going to be when you're in a wheelchair because you broke your hip. So, I don't know, you got to figure out how to phrase it in a politically correct way, but it's still very important because all of these things, when you look at studies and you look at why people fall, environmental issues are really big on the list. So yes, all those things we do physically with the patient are important, but so are these things as well. Environmental hazards, clothing, bad habits are also going to be important to look at. Okay, so now we're going to do an evaluation of a patient. So you have a patient who came to you, they had a fall with or without injury, and it's evaluation day. You're going to look at their prior medical history. Hopefully you have a prior medical history. I've had times where I had to evaluate somebody and I had very, very limited information, basically a physician's order, and that's about all I had to go by with their basic diagnosis. I've heard people, especially who do home health, who may or may not have gotten any kind of a really valuable, they may have something from the hospital, but the person also went through a sniff and they didn't get anything from the sniff, or whatever. I've heard everything. And then I have the alternate problem, which is where I got a bunch of data and I have 250 pages of medical information to wade through and figure out what's important. Ideal situations where you get a wonderful discharge summary that's dated today or yesterday to go by, and you've got this really well-rounded information. Sometimes that happens, but a lot of times you've got to figure it out. Especially if you go and you have a patient who's a poor historian and you don't have a lot to go by, and I've had occasions where the loved one is in the room and you're asking, have you ever had any broken bones? Have you ever had surgery? No. And the loved one's like, honey, yeah you did. You had your knee replaced in 82 and this, whatever. So sometimes they just don't remember, and they're not good historians. So you have to, a lot of times in your analysis of them, you're looking and you see scars and how'd you get this scar? Oh, I forgot about that one. Any recent medical changes? A lot of times what I'll ask is, well, you have a medical history that you can go by, but you can also just go through your triage list and ask about your blood pressure, any kind of symptoms that might go along with that. You ask about what they eat, what your average day looks like, things like that. From a social and a behavioral change, I very often will say, okay, before all this started, whether they had a broken bone, whether they fell or broke something, whether they had a stroke, so whatever led them to the rehab industry, you can ask, okay, go back before this injury. Tell me what your typical day looked like. So you might find out that this is someone who was mostly housebound, or this was someone who was very active. And either one of those things is going to go into your evaluation and help you set goals. I'm not always a big fan of the idea that we're going to go to their prior level of function. A lot of times their prior level of function was really not good. And it's reasonable to expect that they can resume a better life than what they had before. And so I may go back 6 months or a year. So I find out that in the days leading up to the injury, they maybe were at home and you ask, okay, what was your day like? And they say, well, I get up and I watch my shows and I just, watch whatever they do, their little games, but they're mostly homebound and they're inactive. And you say, okay, what about 6 months ago? Have there been any big events in your life? And they may tell you, yeah, my wife died 6 months ago or a year ago or something like that. And you say, okay, well, what was your life like before that? Tell me, and they maybe say, well, she was sick, so I was doing all this for her. And then you say, okay, take me back before she was sick, a year ago or something. And they tell you, well, we used to go here, and we would go there, and we had this social life, and we would travel. And then you look back and you say, okay, is there any reason why this person couldn't resume that life physically and that level of function? And the only reason they haven't, that's their prior level of function, not the depressed week before they fell and broke their hip. It was the one before they started that sort of slow spiral down. And that's what I would do, is I would really highlight this person's true prior level of function which is achievable. And I'll say this prior level of function is reasonably achievable given the current physical findings that I am looking at today. That's often what I will look at. Okay, so any kind of changes that have happened, and a lot of times they'll say, I used to go to church and now I watch it on TV. And why is that? My loved one got sick and we started watching it on TV, and then after she passed away, I never resumed going to church again. So that might be something in a goal. This patient will be able to get to church, attend physically, and then start maybe establishing a better habit. Okay, medication review, we just talked about that one, and using whatever tools you have. Some people, you have to use certain tools, use them. Others don't have tools, so you might need to find one that would be helpful to you to make your job easier, because I can tell you, I don't know every drug I read. Many of them I'm getting more familiar with. A lot of, when you go to new classes of drugs are always coming out. So tools are very necessary, and generally they're very easily available to kind of look at what concerns should I have. Environmental assessment, home assessment, we just talked about that as well. There are tools for that. One of the things is, like, I've got the Cougar Home Safety Assessment back there. It's Cougar, like the animal cougar. It's what university? I think it's Misericordia University. That it's basically one of their OT projects, and they're on like version 4 or 5 if you go on their website. But I've got one of those. It's like the most thorough home assessment you will ever do in your entire life. You probably don't need to do that one, but it's really kind of interesting to look at. And then there's many other forms out there. I know the CDC has a home assessment form that you can use. So finding one and just customizing it for your use. But that's going to be a nice tool to have for yourself. It also can justify further intervention if you need it, and consultation with other people. Maybe if it's PT got ordered to go in and you really think they need OT as well and it didn't get ordered, it can help justify another discipline coming on board. From a physical examination, you want to check their range of motion. Ankle, check your ankle both in flexed and extended. A lot of times people will only check it if they're sitting in a wheelchair. When you encounter them, they may only check it in the chair sitting, but you also want to check it while their leg is extended, which is how they would be when they stand up. So you may have some people who are at 90 sitting in their wheelchair, but then you stand them up and all of a sudden they're minus 10 degrees, which is how they're going to be when they're standing up. Inversion, eversion, that depends. I mean, my evaluation is different for different patients. And that's, I think, makes sense. It should be. Even though some people would argue with me that we need I like customization. Some people want standardization. Standardization within reason. We are not all the same, and some tests and measures are completely unnecessary and inappropriate in some clients versus others. So if I have somebody who is going to be a community ambulator, that's my goal. I'm going to look at forefoot mobility and toe mobility. Those are all going to be important. Which somebody who's never going to walk, I may not want to take the time to do some of these. I'm going to look a little closer at skin integrity, and so somebody who's more wheelchair bound, and if they're getting up and moving around a lot, I may not have to check their ischials. I may not have to check, I may not have to really pay close attention to what's going on in every bony prominence in their skin, versus I really need to get them naked and do a very thorough skin assessment on somebody who has more wheelchair dependency or primary bed dependency. So I want to tailor my eval specifically to that client at this time and what their immediate history has looked like, because that's going to help me identify potential problems and not waste my time or their time if it's unnecessary, because it doesn't make any sense for your eval to take 3 hours if it doesn't have to. Gross strength testing. Again, same idea. Some people, all you need to measure is dorsiflexion, plantar flexion in the ankle. Others, you need inversion, eversion. You need toe mobility. Versus other folks where you don't really need to do that. You maybe, if they're not going to be standing or ambulating, you may not need to focus on that right now. You may notice there's some some problems there, and you have to explore it more. But being a non-ambulator, I might want to take the extra time it's going to take to look at hip extension, and instead of spending that extra time really looking at coordination of the toes and foot. You know what I mean? So spend your time wisely. Sometimes I do gross muscle testing, and then I hone in on where the problem is. So you may be looking at trunk extension, trunk rotation, hip abduction, various things, and then you zoom in. So just hip flexion and extension on someone who is not going to stand or ambulate may be sufficient. Or they're going to be, where you're going to be looking at transfers, but you're not looking at necessary ambulation at this time. Versus hip abduction, you need to look at that stuff. You need to look at abduction if you're looking at somebody who stands and ambulates, or you hope that they will ambulate. Those are going to be important things. So again, figure out what exactly grossly first, and then zoom in on the important parts. And you may have to revisit it. I very often will be even writing up my eval, and I start making notes. Failed to look at this, I need to look at this next time. I forgot to check this, and I need to go back and look at this. While you're writing up your eval, or you're assessing your Byrne balance scale, or best test, whatever test you did, and you're writing up your eval later, and you're like, darn it, I need to check this person's vision. I need to go back and check the sensation in their feet. So as you're writing it up, you're going to say, oh, they did really good on this one, but really bad on this one. How does that add up? And you're like, well, I probably have a sensation impairment. I need to check it's either vision or it's their sensation in their feet. And that leads you to look at something else. Manual muscle testing. I've been surprised. I've had a couple of new grad students that didn't get manual muscle testing in school. It was assistants, not OTs or PTs, where they didn't feel comfortable with it. So I do think that it still stands us out as an industry. I think we're probably the only industry that really does it the way we do it. I work with physiatrists, and they do manual muscle testing, but they're the only physicians that I've really encountered that truly do it the way we do it. I've had a couple of neurologists that graded muscles, and we had some discrepancies as to what I called it and what they called it, but for the most part, it was fairly close to the same. But again, I think it does stand us out, and I think I want to stand by manual muscle testing. I think, and I've been to a couple of meetings and classes where people have stated that it's not objective. What about human evaluation is objective? I mean, really, everything has some degree of subjectivity. But I do believe that manual muscle testing, in my mind, is an objective measure. And I think it's very standardized. I just think it's sometimes hard to do, especially hip extension and hip abduction. Very difficult to do on somebody, especially low functioning, can be very challenging. Handheld dynamometry, there's a course that is advertised on handheld dynamometry I'm looking at going to, but I use it, and I've done it myself sometimes, but very often it's too time consuming for me, and I'm just being straight up honest. I figure out where to spend my time. But sometimes it could be very, very helpful, especially in your really high or really low functioning, where you have to justify something. It can give you some good objective numbers that are hard to quantify based on 4 versus 5, you know what I mean? Functional testing is a huge one. When I think back historically, and I think some things I learned in college, I remember specifically going to my first internship or second internship or something, and I remember I had learned if you don't have at least 3 out of 5 strength in certain key muscles, like plantar flexors, this patient will not be able to walk. Did you guys hear anything like that? Did you ever learn anything like that? Yeah, I was specifically told you must have minimum ability to walk requires at least 3 out of 5 strength. And I remember plantar flexors being one of them. Have you ever seen somebody with less strength than that walk? Oh yeah, I see it all the time. They do it. They defy logic. So just because I learned it in school doesn't mean it's true. Now, do they do it well? No, they compensate all over the place. So there's compensation that happens. But I've seen plenty of people walk without the minimum amount of strength that I was told you had to have. So it didn't make any sense to me, but lo and behold, over years of time, you find that everybody's different, and compensation is a very real thing. And they will come up with some sort of dysfunctional way of getting from point A to point B, and they'll get there, and they just won't do it well. And once that becomes a habit, that's their normal gait pattern. And unless we turn that around, they're never going to get the strength. That's one thing I constantly say, well, if they do it wrong and they do it poorly, making them do it over and over and over again is not necessarily going to be of benefit. Maybe cardiovascular, but it's not going to improve their movement patterns if you allow them to do these things over and over and over again in their poor method. So sometimes we just have to make life harder for them in the immediate period of time, but do it in a good way that's going to helpfully restore things that are capable of being restored. Pain assessment. From a pain assessment standpoint, I mean, this is a little bit of a soapbox of mine when I say we really need to assess it. What's the number one thing that happens if someone says I'm in pain, something hurts? What's the number one not necessarily by us, but by just the world as a whole? Let's give you a pill. Would you agree? The most common thing is to let's give you a pill. That's maybe not wrong. That might be absolutely appropriate. But what needs to come first is an assessment. What hurts? What hurts? What makes it better? What makes it worse? They may just need to turn and reposition. It may be that they are hurting because they've been sitting in a wheelchair and they're poorly positioned in the wheelchair. They need to move. It could be that they're in bed and they need to be repositioned. So to give somebody pain medication just to get rid of those symptoms that could be otherwise treated and gotten rid of in a better way, you want to do it the other way. You want to treat them in a non-medication way. So I deal a lot, I'm sure all of you do too, with people where I would like to try to get them off some of their pain meds. One of my goals is, it's a common goal I write, is patient, whatever terminology you use, resident, whatever your terminology is, will list 3 things they can do prior to requesting a pain pill. Or they will list 3 non-medication interventions that they can do prior to requesting a pain pill. And that way, that is my goal, is that they will be aware and educated on that. Or their loved one, or the nurses, or whoever will list 3 things they can do prior to administering a pain pill. So a lot of times it's just the better way. It may take longer. It may be a little bit more work for us as healthcare clinicians, but it's the better way to do it. What are the side effects from pain meds? Think opiates. What are your most common side effects? Sleepy. What else? I didn't hear it.
Constipation.
Constipation, yes. Also, many people become sedated and disoriented, are sleepy, constipated. Are sleepy, constipated patients good rehab candidates? Not really, because then they take, stool softeners and then the next day you can't see them because they have diarrhea and you stand them up and they have to poop. Plus they usually have to poop anyway halfway through therapy, and that's a good thing. We get things moving, including their gut, which is great.
Seems like
What's that?
the more they're taking it, the less more sensitive they are to pain, more higher level that they perceive it.
Right. Many people actually it's counterproductive. I mean, pain is a very difficult thing. I went to the did anybody go to the FPTA, the recent FPTA convention in Orlando? Okay, I went to it. But one of the classes was about pain med. It was like, I can't remember that modern interpretation of pain and the history of pain management. And I remember he said multiple times, pain's weird. Pain's, very weird. I'm like, it is. It's very difficult to treat, and you can't look at it. Everybody's different. Everybody's problem is different. Everybody's interpretation, everybody's perception of it, and their opinion. But yeah. But when we simply look at how pain medicine works, like the opiates, many of them, they've never been really labeled for musculoskeletal pain, which is what they tend to be using it for in our environment. I mean, they're really mostly studied in cancer pain, but they haven't really been labeled for the use for musculoskeletal pain. But there's nothing really better, and that's, I think, the problem that exists. So it actually acts as a smooth muscle relaxer, so it increases orthostasis, or the risk for orthostasis. It causes you to be sleepy, maybe not very motivated, and constipated, which is, constipation is a real sign of things not going well and not moving, because nothing's moving, including the gut. And it's a very important conversation for everybody, especially in my population with spinal cord injury. It is a definite conversation we have on a daily basis. How was your bowel movement? Did you have one? And we should be having it with our low-level patients for sure, but even our high-level patients, because it's indicative of other things. And many times they will have to have a bowel movement while you're with them, and that's a great sign that whatever you're doing is working. They're breathing, they're moving, and things happen, and they're backed up because they have been, and the fact that they start to go is a very good sign that what you're doing is productive and positive and helpful. But from a pain assessment standpoint, that's a big question to ask. What hurts? Describe your pain. That way you can address it appropriately, and there's lists of words you can ask. Is it burning? Is it superficial? Is it deep? Is it aching? Is it continuous, or is it intermittent? When does it happen? What makes it better? It will help you quantify and figure out the cause of the pain, but also come up with alternatives and help them be more educated and aware, and they very often appreciate all your questions. I'd say most of them do. They may look annoyed, like a lot of you guys look when you're teaching a class, but you've got to assume that they will learn from what you're saying, and when you ask them the questions, they will learn and they will hopefully realize that you are smart, and they'll really value the things that you're saying. Especially when you poop, they poop. Because your older population, they will think you're just magic if they can have a bowel movement. And you could say, that could be a motivator. I have used that as a motivator. Where constipation, the going from constipation to diarrhea is the reason they never go anywhere. Is they're like, well, I never know when I'm gonna have a bowel movement, and I just don't wanna be out and have to go to the bathroom and not know where the bathroom is and blah, blah, blah. And I'll say, well, what would you do? How would you feel if I told you I could have you having a bowel movement on command? If we could time it out where we could get your bowel movements more predictable. Well, I feel that's a reasonable expectation. And where you teach them how to have a good, productive morning routine that results in a bowel movement, whether it's every day or every other day, whatever's appropriate, that can be something that you certainly can use as a bribe material. Okay, so pain assessment is going to be important, and looking at how to work it into your plan and how to assess them right away, and know that when they talk about their pain, the way they talk about it you can interpret it as pain is going to be a big thing we've got to address. They have a poor tolerance for pain. Have you guys read, there's a lot of different things, texts, and pain is a huge topic, agreed? And you could read 100 studies a month because there's that much volume going on in the world. But you've got to think about your own population and what's the most common cause of pain, because it's going to vary. Certainly vary from my setting to a skilled nursing facility to a home health facility or something like that. But when you think about the most common thing that's going on, and you are going to be able to come up with tools that are going to help you to address it. But if you see somebody who you can see you can tell right away that they are, the term catastrophizing. Have you guys heard that term, catastrophizing? Pain catastrophizing? There's a test, pain catastrophizing scale, that I've utilized for people who they're very, very paralyzed by the fear of pain. And so fear avoidance behaviors, like we have the ABC, the Activity Specific Balance Confidence Scale, which is based on not pain, it's how confident are they to go out in the world, but there are also similar tools that are based around this topic of pain, and how afraid of pain are you, and how limited are you by your pain. Because that's also going to be a big deal. If the reason they won't comply is because they're so fearful of pain, then you're going to have to address that, or they're not going to be having success. So again, there's tools available to help you assess people, and that'll help guide your goals and guide your care and interventions. So when you do your functional assessment, think about how it looks. Most of them, if you go back and look at my evals over the years, depending on the setting I was in, after a little bit of time, when I started seeing very similar patients, you could look at each one and they kind of look the same. Agreed? Your evals start to become very, almost predictable, which is okay. That's survival. We have to have that. My question to you is, if that's the case, we're going to take the time to kind of look and see, is there anything missing? Is there any standard thing I could stick in there or subtract that's going to make it more efficient and more effective for me? So you may walk out of here just thinking, I'm doing a great job because my eval is perfect and it really does fit the needs. Or you hopefully will walk out of here with at least an idea or two of something that'll maybe make your evaluation a little better, maybe a little bit more broad or specific, whichever it needs to be. And it may help you make your eval a little easier to do and your evaluation easier to write up and the plan better. Because a lot of times as a PT, I'll communicate with my assistants and encourage them, when I write my goals, it's not enough for them to just read my eval. A lot of times I'll say, take the tool that we used and look, because I'll highlight a few things and I'll say these were key things we really need to work on. So take this task, whether it's picking something up off the floor, and make it a routine part of your rehab program, or if it's turning and looking over the shoulder that they had a really hard time with, take that task, because you can make that fun, whether it's throwing something or whatever. You can take that and you can make it a fun task. You can make it a regular routine in their plan of care, but it helps, that communication level helps and expedites their recovery. So when I say functional assessment, yes, you're going to look at their bed mobility, you're going to look at their transfers, look at all of those things. You're going to look at their balance and ambulation. But when I say balance, let's just talk for a little bit. I have a slide here. Yeah, measuring balance. Let's talk about measuring balance, objective measures. This is probably what I see the most. And I'm not, everybody's different what they're doing, but the most things I see are, they're rating their balance, static and dynamic. And I'll see static balance is whatever, it's poor or it's fair, meaning fair would be I don't have to touch them, but if I did touch them in this way, they can't tolerate it. But they can stay there, but they can't do anything from there. Or fair minus, if I just kind of have to touch them a little bit, But basically, it is, we could argue again, it's objective, but it's probably not enough. If one of your goals is going to be balance, that's not enough. You need something a little bit more detailed to look at it. And that's, in this day and age, the requirement for objective standardized testing is there, it's big, and we're going to have to comply with it. So you're going to want to look at different tests that are available. There's too many of them. I think, what was it I read? There was a study, I think the author was O-R-R, and I think it's a he, I don't remember the first name, but this researcher looked at how many standardized tests were there. And this was like, I don't know, it was old, it was like, probably more than 10 years ago. But it just stands out in my mind. At the time, there were 68 standardized tests that assessed balance. 68. Do you need 68 tests? Heck no, I can't, no. I can barely remember the 3 I do on a regular basis, so I don't need more than that. There's more since then, for sure, because we now have the best test, the mini best, and the brief best. All of those are just 3, and I know there's at least 2 or 10 more, probably. So which test is best? What's best for me doesn't mean it's best for you. It's going to be, and there is a test called the best test, actually. If you're not familiar with it, you will be, because we're going to talk about it. But you're going to have to figure it out. You may need tests and scales that look more at sitting balance. So you might want to be looking at, a sitting balance scale, because you're really working on their ability to perform a slide board transfer, and they're not going to stand. So a tool that looks at standing balance is not going to be effective or useful at all with that population or that particular patient. Maybe they get up and they walk. If this is someone who you're thinking they're going to have the potential to be a community ambulator, then the Berg balance scale is just not going to be effective enough. That's not going to be, they're going to top out on it and they're going to get a perfect score. And that's going to make it look like they don't need therapy. So when you start thinking about these standardized tests, there's a couple of things to think about. It needs to give you information. So I want this test to be able to not, the ceiling and the floor need to work. So if the floor is basically how you get a 0, and the ceiling is how good you have to be to get the highest score. So if the ceiling isn't high enough, like let's say that community ambulator is probably going to get a perfect score, so on the day 1 on the eval, on the birth, simply because it's just not a high level test. But if you're in a nursing home situation, if you're in a SNF, and you're trying to get somebody to the point where they can transfer themselves safely and maybe stand and do some functional tasks, but you're looking at someone who's not likely going to be, or at least not while you're seeing them, not likely going to be an independent ambulator, the Berg balance scale might be something perfectly appropriate for you, because it's looking more at standing and transferring and a little bit more limited versus somebody who walks. So we'll go through a variety of tests, low level, medium level, high level, and and you hopefully will come up with some that you're thinking will be good. I don't use the same tests on everybody. I love the fact that I get broad. I have people who are quadriplegic, and none of these standardized tests are anything they're ever going to be able to do, because they are completely dependent for care, and they will be for the rest of their lives. And then I have people who have a brain injury, but it's a mild brain injury, and they're gonna be ambulators, and they're probably gonna return to a sport, or they're gonna return to a job. And they're gonna need much more intensive testing in order to be able to capture deficits and identify problems that we can address and put goals in place. So that's gonna determine based on yours. And then from a confidence standpoint, you're very often gonna have something looking at their confidence and their fear. And that's gonna allow you to also address those issues and make sure that they're brought out. Because very often I end up with getting people psychological counseling, and you guys may too. You may find people that could use counseling and that wasn't even considered or thought about. And if it's for comp or it's some third-party insurance, or they need, then your documentation can help them get that paid for, hopefully. Okay, so the other thing to think about with these tests is the time-consuming. How time-consuming are they? So you may look at a test and think, boy, this is really great, but it's going to take so much time to do. I'm just not going to do it. And when we talk about best test, that's one that has evolved very quickly because it just, I think, was too time-consuming, and people liked it, but found it way too, too challenging to try to meet that need. Are you guys busy at work? Are you required to be efficient? Yeah, I get it. Yeah, so that's where these tools can help too. Is if you find one that will help you be more efficient and give you a more, what do they say, bang for your buck? Give you more bang for your buck. And also how you administer them. I definitely think when you come up with standard tools that you use, and if you use them along with other people, let's say that you're the evaluating therapist and you work very closely with a certain PT assistant or a CODA, and you guys work together a lot, it would be beneficial when you are using a tool that you're not as familiar with, that you do it together for a couple of them, and that you guys make sure that you're doing things the same. Because you may do a test, and the next person is doing it, and you observe them touching the patient, and then you say, what did you score them? And they score them what you wouldn't have scored. Because you say, well, you touched them. You said, I didn't help at all. And you're saying, you did. You did. You touched her elbow, you touched her gait belt, you touched her hip. Technically, do it again. This time, don't touch. If you feel you had to touch, it was for safety reasons, I felt it was not safe for me not to touch that person, then you score them with assistance. So again, if you guys score the same, that's going to help you be as objective and measurable as possible. And make sure you're not wasting your energy on something that's not necessary, and it'll guide your care so you're effective. Functional reach. Now, some of these I want to talk about because they're popular. These two are very popular. Not that they're my favorite by any means. Certainly not the functional reach. It's not one of my favorites at all. But it is super popular, and I see it used a lot, especially by physicians. And I think physicians will use, like in a physician clinic, a lot of times they use the tug and the functional reach. Do you see that? In an outpatient, like when they go into a general practitioner. And I just think it's probably Medicare guided or some resource that's very common said that these were big tests. And the mini mental, a lot of times they'll have these 3 tests right in a row and then score on them. The functional reach is part of many other tests. So like it's on the Bird Balance Scale. It basically has you put your arms out, and without rotating or moving your legs in any way or your feet, you're supposed to reach forward as far as you can and then back. There's also, that's the most common one. I gave some interpretation, but there's many interpretations. So longer a tool has been around, the more when you search it, you'll find many interpretations of it. So you'll find research studies that says, in our study, increasing by 2 inches or more was a meaningful change based on results, but by comparison to studies, something like that. So you may find the one that you like. You're like, okay, that one's a good one. I'm going to use this one, and this is a meaningful improvement based on this research study. There's also, in some other tests, they have the multi-directional reach, which you reach forward, then you reach to the side, reach the other side, and you lean back. So that's another tool that you could use. Now, one of the things I've created, but you don't necessarily need it, is just a sort of list of tools that are out there, and it's not all-inclusive because it doesn't have anywhere near 68 tests on it. And then I rate it as low, medium, or high level test. And just for my own use, and it'll allow you to pick up one. So I have some examples of it back there. Those of you at home, if you want, I can email it to you. But it basically will help you if you say, well, she has these two listed as low level. And I looked at them and they're okay, but what you can do is you can go on one of these search engines like the Shirley Ryan Ability Lab that I gave you earlier, and there's other search engines that you can use that have databases of balance studies, and you can plug that test in and you can say, show me more like it. And that way, if you know you need, in general, you need such sort of low to moderate level test, find a test that's available. Like, let's say you say Berg is pretty good. Like, the Berg's a pretty good test, but I want to see what others like it. You can plug it in and it'll basically kind of show you other tools that are like it, or you can go through their examination of that Berg's test and see what they use as key indicators from it, and you can click on that. And it'll also give you a link to other tests that also look at similar key indicators. Now the timed up and go is, I do like this test for ambulating patients, but we'll talk about the pros and the cons of all these tests. Well, the pros and the cons of the functional reach is, it doesn't really, just having the ability to stand up and reach doesn't necessarily tell you a whole lot about that patient. So it's a very limited test. Usually it's a piece of others. So it's one piece of many questions on the test, and I think it fits more there. To use it as a standalone is probably not going to be a very good indicator of their fall risk. It should be a part of other things. So I think, again, it's a good piece. Now the timed up and go, you have the patient stand up, they walk, so basically they're sitting in a standard chair, and you mark 10 feet from them. So 10 feet or 3 meters. And so you mark it, and you have them do a trial. I think the original instructions will tell you that you give them instructions, then you have them do a test run, and then you time them. And so basically you say, when I say go, I want you to get up, walk to the marked area, turn around, walk back, sit back down again. So they're supposed to wear what they normally wear, use whatever they normally use. So one of the good things about it, it's one of the few tools where they can use a cane or a walker or something, and they don't automatically fail completely. It's like on the Berg balance scale, technically, you would have to give them the lowest score, assuming they use their tool on every number. So this one allows you to do it, but if they really do need the walker, they're probably not going to do well on the test. It's probably going to take them time. But you've got those people who get up and they kind of carry it with them, and we got things to talk about maybe. But so basically, this is again one interpretation of less than 10 seconds or more than 10 seconds as being a normal. Instructions make a huge difference, and how you instruct the patient is going to make a difference. If I say walk at your normal pace, it can make a gigantic difference. Or if I say go as fast as you're comfortable. Those two different instructions can make or break it. Because if you say walk at your normal pace, I mean, some people are on a constant Sunday, they're just not in any hurry. So you got to think about how you instruct them. So I want you to walk as fast as you're comfortable but safe. Would make them kind of walk faster, and if you let them know that you're timing them. So it is a timed test. You know, when we talk about timing, I mean, sometimes I want a timed test. All tests are not timed. What does time tell you? I mean, to me, it tells me agility. It tells me how they're going to react when they're in a hurry and how quickly they can get there. So, I mean, it gives you a little piece of the puzzle, but it's not always the only meaningful thing. So just because what you document is the time, I also think it's meaningful to note that the majority of their time was spent getting up out of the chair and resuming sitting in the chair. Once they got up, their walking was pretty darn good. They had a really difficult time with the sit to stand and the stand to sit. Versus someone who got up well and they walked very well, but they had a difficult time with the turn to get back and the turn to sit down. Again, very meaningful that somebody has a hard time turning, or they maybe looked off balance when they turned. Quickly, I'm going to know I need to test more. I need to test their vestibular system, because certain indications are going to tell you they had a problem with rotation versus they had a problem with the movement up and down. It's going to lead your eval to go in the right direction. Yes, sir?
I know since you've used this test quite a bit, the up and go, I have a hard time feeling safe, feeling that this patient's safe to walk without me touching them.
Right.
You know, and I'm wondering, I've heard people say, you can't use that test because you touched them. So I'm like, I don't even want to use the test if I don't feel that I can safely guard the patient.
Right, so they require assistance.
So you can do the test and state they required assistance, Even though
Yeah,
some
well,
of the tests say
basically
you're supposed to
unable
be
to complete
independent.
the test without physical assistance. And then that would lead me to maybe do a different test.
Mhm.
So a test that involves ambulation, that would look further at ambulation. We're gonna cover a good number of those tests as well. So when I see why I needed to help them, at what point. So for me, let's say that they walked straight pretty well, but when they turned is when they had a problem. So and maybe I walked along with them, but I didn't actually touch them.
Mhm.
So I walked along with them. I never had to touch them until they turned. And at that point, I had to touch them because they turned and, did this
Yeah.
kind of thing. Right away, I know another test I would do.
Is that test void then, or you just say something like?
I mean, you may say I administered the timed up and go and they required assistance with the turn. You know what I mean? So
Mhm.
in the end, if you had to assist them and back on their feet and they kind of stopped for a minute and then they continued to walk and then they had problems turning again to sit, I would say that the timing is really not super useful for me because the problem that they had, I need to address further. And, you still could record the time if you wanted to with, and this is why, and this is what happened, but it would, right away, I would just say, you know what, we need to do another test. Like, I'd probably go to a functional gait assessment or something of that nature because or even a bird, because that's gonna incorporate these kinds of things, and that's gonna help you figure out what types of rotational problems are gonna be happening, and it'll give you a little bit more of a broad picture of those types of movements. So, again, the timed up and go can be good, but then you can have somebody who does a timed up and go, and they do pretty well, and then you do a timed up and go with a dual task, and then all of a sudden they don't do well at all. So when you think about a dual task, a lot of people will prioritize, and you can even tell them, you have them do the counting method, and then they do the actual walking method, and then you combine the two, and you can tell right away, you can say, you give them no instructions and they get up and they count really well, but they go very slow. So they get the counting right, but they get the speed wrong, bad. And then you can say, okay, I want to do it again. This time I want you to go as fast as you can and try to make the speed as your priority here. And then you can kind of judge by how their cognition goes out the window in the test as well. So you can direct it a certain way. If you are left scratching your head as to why, it gives you another direction to go. And more tests that you can do. Okay, but yeah, so the timed up and go, again, it's a simple, it doesn't require a lot of equipment. It's nice to do tests and have tests available to you that don't require any equipment because it's just easier for your life, especially if you run up and down the stairs all day long, and it's easier to go without an armful of equipment or a big cart. Okay, so the Berg balance scale is a common one. I'd say that when you look at most research studies on balance tests and new tests that have come out, so many of them say, well, it's validated based on comparison to the Berg balance scale. So it's been around for so long and it's been so heavily tested. You will also see versions that have come out that are different. I've seen versions where people have, like I've gone to facilities where I'm using they've got files of Berg balance scales and you pull one out and you're like, well, this is different. Like the wording is different or they modified it in some way. So the one I've got here was from the APTA website, so hopefully it's the one you want to look at. But when you just look overall at the scale, it's really looking to me at functional mobility but not gait. It's looking at transfers for the most part. I think is the most. So I would define it as low to moderate level, but again, depending on your setting, you may think of it as high level because most of your patients don't become ambulators. So if your bulk of your population does not ambulate and is not going to ambulate, then the Berg may be your high-level test that you use in your facility by comparison to the population you treat. You see what I'm saying? So basically it looks at sit to stand and, have them move into a standing position, try not to use your hands. And watching how dependent are they on using their hands, how difficult is it, can they do it, and the quality of the movement. Stand unsupported, so you just have them stand there. Once they get to standing, the ability to stay and stand unsupported. Sitting with their back unsupported, which if they do the stand unsupported and they get the full score, you skip the sitting one, at least that's the instructions. I still want to see them sit. Personally, I still want to see them sit, and if they're sitting asymmetrically or if they're sitting in a way, because sometimes I find they're sitting even though the balance may be okay, it's asymmetrical, or there's something about it that I find meaningful. So I still want to look at their sitting balance and observe them in a sitting position. Stand to sit, so how do they sit back down? Do they plop? Is it controlled? Are they definitely requiring their upper extremities? Transfers, this has them go from a surface without arms to a surface with arms. So they go from one surface to another. So it could be from the bed to a wheelchair and back. It could be 2 chairs, one with arms, one without. And then that transfer, and again, you're looking at their level of independence, how safely they do it, how much use of their arms they have, whether it's definite use of their arms or minimal use of their arms. And again, doing this with your coworkers that you use a lot and that may see the same patients is helpful from time to time, especially when there's those little ones where you say, oh no, I would have said minimal use of arms, and you may have said definite use of arms, and you can compare notes as to why you might score them differently, and it will help you eliminate some conflicting behavior, especially if you're more generous on the eval and then they look like they got worse. So yeah, I definitely think you want to kind of compare notes with your coworkers. Standing with eyes closed, so standing, that's okay. So standing in a comfortable position with their eyes closed, and standing feet together. So when you think about it, okay, so standing with your eyes closed, it's kind of right off the CTSIB. Remember the CTSIB, you're standing on a hard floor, eyes open, you've got all your resources available to you, and then you close your eyes. If they don't do well on that one, what would that mean to you? So if you have them standing and they look great, and then they close their eyes and they start really swaying. So you're thinking vestibular? What else? So you might test your vestibular system, and you'll find more information on that here. That's coming soon, because we'll be looking around and so forth. But what else? Sensory. Check the sensation in their feet. So again, some of these things that we often forget to check, the tests themselves, when you analyze them, it's going to guide you to do the right thing anyway. Because I'm right away going to say, if they look pretty darn good, I mean, this technically is the Romberg. So there's a lot of tests that are on their own, it's one test. So the Romberg is just stand with your eyes open and then eyes closed, and you're looking at an increase in postural sway. So if that's basically just one part of the verb. If you see a positive, they start swaying, or God forbid, you have to catch them, it's that bad. Right away, you know either their vestibular or their sensation is really not good combined, or one or the other is really not functioning. So it may be both. So standing with eyes closed, standing with feet together. What does that do? When you decrease your base of support. Yeah, you decrease your base of support, but you kind of decrease some of that somatosensory. You just make it more challenging, but you definitely have to have good sensation in your feet. Feet together and eyes closed would really be a vestibular test. Reaching forward, that's the functional reach that we just talked about. So you reach forward with an outstretched arm, and people will all try to go like this. They're all going to try to do something they're not allowed to do. So you got to, measure. And why can't they do it? That's the big, to me, it's not the number. The number, yes, is going to be an objective measure to start with, an objective number to prove that what we did is working. But the reason why is going to help me figure out what to do to make them better in order to guide the care. Pick up an object from the floor. So it tells you to use a slipper. I think a slipper is the suggested item. I have a bunch of little swimming pool noodle cut up, which is kind of similar to the weight and shape of a slipper. But many people, when I say, if you don't have a slipper on you, what do you use? A lot of people tell me they put their pen on the floor. Is a pen the same as a slipper? No. I don't want to test your fine motor skills in your hand and your finger dexterity so much. I mean, I'm not saying that you can't use that as a tool that would be informative to you, but it's not the same. It's not comparative. And if the next person that does the test doesn't use the same method, if you used a slipper and then the person who repeats the test in a week uses a pen, it may look like they got worse, because that's going to be harder to do. It's a couple centimeters further down, and it's really much harder to grasp if you have a grasping problem. But you're identifying the wrong problem if grasp is not what you're working on. Okay, so pick up an object from the floor. I also have people who I put the object on the floor, whatever it is, an actual slipper or shoe or a piece of foam or something. I have the people who kind of kick it to the wall, kick it closer to the bed, and then they grab the bed and they bend over and pick it up, and I'm like, okay, good problem solver. But let's try it again without touching anything. You know, it can help you get insight into the person and their, you know, whether they have the sense to not, you know, whether they do these things or whether it's unnecessary. So you notice they kicked it over and they tried and walked, you know, they did something, and then you had them repeat it, and they actually did they did the movement pretty well, and they didn't have to take those accommodations. Then you might all of a sudden be on to the fact that this person is someone going to make their life easy on every occasion. What is it they say, take the more challenging road or take the easy road? They may be someone that you're seeing insight into the fact that they're going to take the easy road every time, and you may have to talk to them about that. Park farther away and walk further in the parking lot. Take the stairs. You know, but we find a way to make it fun, because if you have someone who automatically just doesn't challenge themselves, they're gonna go downhill faster. Look over left and right shoulder. Okay, so you turn and look over one shoulder, you see how well they can rotate and turn, and you know, this may help you identify cervical range of motion problems. It can help you identify weight shifting problems, trunk rotation. I mean, when you think about who's gonna have a problem with this. Well, from a range of motion standpoint, Parkinson's comes to mind. Anybody who has had spinal fusion, you know, I mean, so when you can automatically see why. Clearly, Parkinson's or spinal fusion will be different than the person who is able to do the looking, so they do it, and you're writing your little note, and you notice them going, woo, oh boy, you know, so you have a delayed reaction. That's more vestibular. So if you have someone who, it's the rotational motion that bothers them and they start to sway, versus the ability to rotate. So that's also going to be helpful to you in saying, okay, I need to further explore, not range of motion, but I need to further explore vestibular function. So again, it's going to guide your care, make you more efficient, help you identify their problems. Turn 360 degrees. So you turn one way, you turn around the other way. Kind of the same idea. How did they do? Were they able to turn around? It's a weight shifting problem, a range of motion problem, or it could be a general balance problem, which is everything. Their whole body, they have a little bit of a decrease of everything. And so you're gonna have a well-rounded program versus someone who has a very specific problem that is limiting their ability. This could be hip rotation, range of motion versus a vestibular problem. They spin around and they have to go real slow because they keep they keep getting really disoriented because of the vestibular issue. Alternate one foot up on a step stool. So I have some shoe boxes and a step stool back there. You basically have them tap 8 times in a row. So there's so much that goes into that. You know, can they tap one foot but not the other? And why? Clearly, if they had a fractured hip or stroke or something, that's going to be indicative of one limb not being able to move as well. They may have more problems with the limb in the stance versus the touch. So it could be that they have a hard time lifting the limb because it's limited hip flexion, or they could have a problem because they couldn't stand on the right leg. And that's where you can observe and figure it out. So it's not just doing the task and could they do it, but why couldn't they do it? And do you need to focus on weight bearing on the right, and you need to focus on coordination and flexion and, you know, agility on the left. You know, so you're going to be looking at what the problems are so you can address them. Tandem stance, you basically go heel-toe stance and stand there. So again, your question isn't going to be, it's going to be the score on how well they did it, but you're also going to be looking at what's the limitation. I mean, I've had a lot of people who, they're very obese, so they can't get in that position. They physically can't attain that, so that's something you note. It's not that they couldn't, but they scored less because they could only get one foot in front of the other. They couldn't get them in full alignment, but that's not going to be corrected by my therapy sessions, you know, at least not quickly. Or they were able to get there, but they couldn't maintain it, versus once they got there, they could maintain it, but they had a hard time getting to that position. So those are all, again, things to look at. Also, is their weight, do they bear the weight on the posterior foot or the anterior foot? And when you look at what they do, the one positive and negative, I mean, probably negative in my opinion, is that all these single limb things, it doesn't tell you which limb. You let them patient choice. Patient can choose which leg they just choose to put out front. And sometimes if you have them do the other one, it may be even worse. They may have a harder time doing it with the other one. And is that important? my question would be, are they at times going to have, if you're gonna put one foot in front of the other, are you also gonna have to do the reverse of that? Is that gonna be necessary? Then I kind of wanna see it the other way, you know what I mean? So tandem stance and then single leg stance. So the most challenging of positions would be in the single leg stance. Can they do it again? It doesn't dictate which leg, but you may want to, if you think they're gonna walk, you're gonna need to be able to stand on both legs. And that's gonna define whether they can do it or not. Questions or thoughts on this? How many of you guys use the bird regularly? Yeah, a lot of us do, so sorry, you're like, okay, here I am seeing the bird again, I've done it a million times, but, so there, some interesting things is there's been some studies that looked at the individual items versus the whole bird. This particular one, Alzager, found that when they looked at multiple people where they performed the test, the single lower extremity stance, the score was as helpful as the whole score. And picking up an object from the floor, this author found that it was better at screening, the best one at screening fallers, meaning if you only had time to do one thing, that item, and if your purpose is to figure out screen for fallers, so if it's more of a screen and not an evaluation, and you're trying to look at a quick thing, a quick look, this kind of thing matters. But if you're trying to do a full evaluation and come up with a holistic, well-rounded plan of care, I would do the whole test. Make sense? Now think about maintaining stability. The idea that if somebody knows what you're gonna do, you tell them what you're gonna do, they are able to get prepared. So a lot of these tests, they're warned, you know what is expected of them, and they're prepared to do it. But that doesn't necessarily test their reaction time and tell you how quickly they can react to something. So proactive control is basically, they're reacting to, they're responding to something they know is gonna happen, or it's experience-based. They've stood up before, they've done this movement before, it's not something new and unexpected, so it may be an important thing to watch, but it may not tell you how well they're gonna do to unexpected things. So reactive control is basically giving them unpredicted challenges. So throwing something at them unexpectedly. This is a challenging thing to do, because sometimes it'll make them scared of you and never wanna meet you. They may think, I don't wanna come here again. If you're in an outpatient center, that's not good. They may not come back for their next visit. But basically the idea that they have to respond immediately to unexpected challenges is something we need to be doing. If we have someone that we're going to be putting them in a situation, they're gonna be a community ambulance. They're gonna go home where things are gonna happen that are gonna challenge them. You have to be able to test these things and rehab these things. So the bird balance scale, you can say, does not do that. You instruct them, you tell them what's expected of them, and they do it. But they're really not expected to do anything suddenly. There's no unexpected things. So when we start looking at different tests that can do that, we'll talk about a few. Now Kinetic, that's one that's supposed to do that. So basically the Kinetic Performance-Oriented Mobility Assessment, or PAMA, it's intended to assess balance and gait as needed for, basically it's a lot like the bird. I think we would all agree it's very similar to the bird in that portion, but there's also a gait portion of it as well. So there's a few different versions that I've seen that exist. If you have a balance portion, which if you do that, you're supposed to say PAMA B, and then there's the gait portion. If you do that, which I doubt, I shouldn't judge, but I rarely see anybody using just the gait portion, but it would be the PAMA G, and if you do both portions, it's the PAMA T, the total. When you look at the Kinetic, a lot of it is almost word for word or very, very, very similar to the bird. So many of the same things. So to stand, it does break down the first portion of standing and then standing a little longer. What might that matter? Because the bird doesn't do that. The Kinetic, you break down being able to stand right away and then being able to stand longer period of time. Well, that might matter, because you may have somebody who stands up and they do okay, but then all of a sudden they get real wobbly. I mean, when I think about why that might happen, it could be orthostasis. It could be that they stand up and they're okay, but then they become orthostatic and so they lose their balance. It could be somebody who is standing and they can do it for a little bit, but then they quickly fatigue and and can't maintain their balance. But again, figuring out why, again, could lead you to further evaluate them and find something that you would have otherwise missed. But the one thing that they add that's different is the nudge. They have a sternal nudge. And so basically, you're supposed to push the patient. You're supposed to push on them. The problem I have with that is everybody kind of does it different. You know, you're supposed to do it the same, but it's hard to. And then you shouldn't, you know, do you warn them? Or, because if you warn them, it takes away the whole purpose of it being an unexpected perturbation. So you really shouldn't push them. I mean, tell them you're going to push them. They should be unexpected. But if you just all of a sudden shove them out of the blue, they may think you're mean, and you know, I mean, you know, if they're already scared of you and scaredy cats, then you could really hurt your rapport with them. So it is a challenge, and you know, you may at the beginning of the test say, at some point I may push you, but I'm not being mean. It's just a part of the test, but I can't warn you when I'm going to do it. Well, then they're terrified through the whole thing. So again, it can be challenging. Now the gait portion of it looks at their various things like the step width, step length, their direction and how much they may sway off of the direction. It looks at a variety of different things. So I have copies of the Kinetic that we can practice in our lab, but I also have a few other gait ones that I want to cover because they look a little bit more broadly at gait, so I'm going to hold off on that one. So moving on to talk about the dynamic gait index. So when you're looking at ambulation and you're testing ambulation, the dynamic gait index came out first. It preceded the functional gait assessment, but it looks at a variety of different gait scenarios. And you need a hallway, basically, or an open area. So you need to be able to look at them walking a fairly decent distance. And so you're looking at walking on a level surface. Just have them walk back and forth, up and down a hallway. Changing gait speed. So you basically have them walking, and you say, when I tell you to, I want you to walk as fast as you can. And then when I tell you to, and I want you to walk fast and keep walking fast until I tell you otherwise. And then when I tell you to walk slow, I want you to walk slow until I tell you otherwise. And so you measure. So you have them start walking at their normal pace, and then you say fast, and have them walk fast, and then now slow. I want you to walk slow. So you do have to have a significant amount of space to do this testing. And the scoring goes into basically, does the quality of the gait change when they speed up or slow down? Do they not speed up or slow down? Is it hard to even see a difference between fast and slow? And then when you think about why that might happen, so their ability to change in gait speed. And then there's horizontal and vertical head turns. So you basically tell them, I want you to walk, and when I tell you to, I want you to look right. And I want you to look right and keep looking right and don't stop walking. And then when I tell you to, when I tell you look left, I want you to look left, keep looking left and keep walking. So you have them walk, look right, and then look left, and then, you know, now you can look forward, or stop. The idea is to see if there's a change. Are they able to do it? And then whether it's physical limitations or whether it's that they just couldn't balance and look sideways. And did they slow down? Did they almost fall and they required assistance? That's all going to affect the scoring of it. And then you do the same idea with vertical. So you have them walk, I want you to walk, and when I tell you to, I want you to look up. And then when I tell you, and keep looking up. And then again, until I tell you otherwise. And then you may tell them to then say, I want you to look down and keep walking. So sometimes you have to kind of run through it, and sometimes the ability to follow the command may be a little more difficult, more because of cognition or just their ability to communicate, but you've got to kind of get a look at the whole thing. So those are really helpful for looking at vestibular problems in someone who is not capable of continuing to keep their head sideways, or they start, you know, doing this kind of really dysfunctional gait where they lose their balance. Gait with pivot turns. So basically you tell them, I want you to walk and keep walking. And when I tell you to, when I say stop, I want you to turn and stop. You know, you basically demonstrate and then have them do it. And so the scoring is based on how many steps it takes them to turn, extended period of time, do they lose their balance? Because sometimes you'll have somebody who starts to turn and then they stumble or lose their balance. And so, let's say we're doing the time up and go, and you notice they had a hard time with the turn, and you're not 100% sure why, but it didn't seem like it was their joints. It wasn't their physical pain or range of motion, and it might lead you to do a test like this, that will help you determine, was it the head turn that was the problem? What is it that gives them, it can help you sort of identify a little bit more and also give you ideas for where to go from here in your plan of care, and maybe a little bit of a broader objective score that's going to help you maybe identify room for improvement. So gait with pivot turn, step over an obstacle. So it has you do either one shoebox or two shoeboxes. A lot of times I'll use one shoebox and then I'll stand it on its end for the two shoeboxes. It gives you the measurements and so forth. I've got some boxes back there. I used to be really careful and measure the boxes and try to make them perfect, but now you get whatever shoes we bought recently. So they're just not exactly specific to the test itself, but in a testing environment, you should try to be as close to the specific measurements that they want. So you have them walk and step over an obstacle, which is basically your shoeboxes or stacked shoeboxes. And you're looking at for the score is, do they slow down? You know, are they able to do it and just basically not even change their pace at all? Versus do they slow down and they have to negotiate it? Or can they not do it or they kick over the box? Things of that nature. So those are all going to be based on how you score them. Step around obstacles. Same idea, but you have them walk and go around the obstacle and then come back and go around the obstacle. And then go up and down steps. So you have them go up and down stairs and you grade their ability to do it. Now the functional gait assessment is very similar, but they tried to raise the ceiling a little bit. So I think what was identified is there were some missing ideas that would really dictate whether somebody was going to be a successful community ambulator or not. So the functional gait assessment, that's the one I tend to use a lot. I use it quite frequently with our higher level TBI patients. So it looks at gait on level surface. A lot of it is very similar, changing gait speed, horizontal and vertical head turns, pivot turn, stepping over an obstacle. They got rid of around an obstacle, so they eliminated that one. But this one has you do a tandem gait, so heel-toe gait, narrow base of support. It has you walk with eyes closed, which can be so eye-opening. Is that a turn of events or whatever? Little oxymoron. Having them walk with their eyes closed is very useful. A lot of times it will reveal something you didn't see coming. Walking backwards is also something very helpful, and looking at the speed in which they do it, the direction they go, any kind of disorientation they may get. So again, the functional gait assessment, and then there's steps. They eliminate one, but then they added a couple more measures. So this can be great for your functional ambulators, the ones that might have some vestibular hypofunction, help you capture that. Now the BEST test, the Balance Evaluation System test is a very long test, but it's a really thorough one. It was developed to identify and help you guide your care. So it was designed to look at sections. So basically it's the intention, if you read the original research, so if you go on their website, there's a whole BEST test, I think it's called besttestus.com, something like that. If you just go on BEST test, balance testing, that'll probably be the very first thing that pops up for you. Or if you go on that rehab measures website that I gave you at the very beginning, you can go under BEST test and it'll link you to the website. It'll also have some analysis of the test. But if you go on there, they actually have videos and the handouts. You can print out the test itself. I have a couple that will be available for the lab if you want to go through the test. But it also has the original research. I use it sometimes for an in-service. So let's say, I don't know if you guys have to go back to work. Some companies will pay for your class if you come back and you in-service staff or something like that. But sometimes I'll suggest go get the BEST test original research article off their website, and you can use it as like a homework assignment the night before my presentation. I'd like you to read this article, and then you can kind of review it. Many studies will do the same thing as this one did, which was a little analysis of balance testing, historic analysis of how we've tested balance through time. What's the pros and the cons, and what are the test failures? Where have we failed in the past, and where do our current tests fail us? And then it goes over an overview of balance in general and why they made this test the way that they did. So it's a very nice, well-rounded educational tool on balance. But basically it has 36 items and they have them grouped into 6 systems. And it's intended that if you score each of the 6 different areas, it'll kind of stand out as to what they're typical problem is. So they may do well on a few of the sections and really poorly on individual sections, which is indicative of they have a problem in this area, which is supposed to guide your care. I think you're going to get that with any standardized test you do based on your knowledge and you looking at them and observing them doing each of these different strategies is going to help you identify. But some of these tools, that's their purpose and they're set up that way so the score will sort of dictate what the problem is. So they look at biomechanical constraints, things like ankle strength, have you sit down on the floor and get back up again. So it's a pretty high level test, but if you have somebody where you need them to be high level, this is a good tool to have that you may not even do the test on day one, or you say attempted to do this test, however, client's endurance is not tolerable to the full test, or they needed assistance, became whatever the problem was. But you could say one of the goals before finishing treatment is they will be able to successfully complete the entire test in one treatment session and will score such and so score or above. So your goal may be that even though they couldn't even do it today, they couldn't complete the test, my goal would be that they should be able to complete this test, which, if they're going to be work ready or they're going to be ready to go and be an independent ambulator, you can use this as your objective measure whether they are safe for that reason. So biomechanical constraints, stability limits to verticality. So the functional reach forward and lateral, it uses that basically functional reach forward, lateral, and posterior. Anticipatory postural adjustments, just an example is looking at their sit to stand. Postural responses. This is what I really like about this test is it uses compensatory stepping correction instead of like the Kinetic where it uses the nudge, it uses the sternal nudge. It doesn't exactly give them an unanticipated challenge. But this does, and it does it in a way that isn't as mean. You know what I'm saying? So basically this one, compensatory stepping, if we were going to do forward compensatory stepping, you have the patient stand there, and you put your hands on them, and you push on them. And you tell them, I'm going to push on you, and I'm going to really push. I want you to push back. And you say, at some point, I'm not going to tell you when, but at some point I'm going to let go. And I want you to do anything you have to do to not fall, but trust me, I will not let you fall. That way you can take the fear out of it, but you can take the predictability and you can predict and tell them, I'm going to do this to you, but you cannot tell them when. And so you still give them an unexpected perturbation, but you do it in a way that hopefully is a little more well received and they're not going to be mad at you and not terrified, and then they trust you. Now if you're little and they're big, you may not be able to do this test on them. The reality is if you're 5'2" and you have a 6'2" patient, this is not a test you're going to be able to put on to them, especially if it's probable that they're going to need you to assist them. So some of them you may have to get a partner to help or something like that. But most of the time, within reason, you could do the test on someone who's even a little bit bigger than you. I've had many people say, yeah, like you're going to be able to catch me. I'll be like, you'd be surprised. I got this, and I'll go get a partner and I'll say, fall on me. I have to prove myself. But regardless, you've got to make sure they trust that you're going to be able to catch them if you need to. So basically you do that forward, you do it backwards, and you do it side to side. So you push on their hip and have them push into you, and then you let go. Now the result is basically, I don't know verbatim the words, but the instructions are they must take a step or attempt to take a step, and you have to stop them from falling. If they don't, let's say you push, and when you let go, arms come out or something like that, but they are able to maintain their balance without taking a step. You have to do it again, and you have to challenge them more. I have had people, especially in the classes, who I have to really push them really outside the limits of their stability in order to make them have to take a step, because they just have such great balance and other strategies that they can use. But the idea of this is they want you to test their ability to take that step. So I do like this one. When I was in school, this test didn't exist, but we learned this as a push and release tool. And so if you look back to the original push and release tool, you would push on them and then let them know at some point I'm going to release you, and you have to. But it didn't require them to take a step. I don't remember the exact scoring off the top of my head, but there was a little bit more room for, that is a tool that you certainly could look up. If you only want that, and you would like to look at a different comparable scoring technique, you could look up that test as well, and the original research on it. So compensatory stepping, that's why they call it that. Sensory orientation is basically a modified CTSIB test. So remember that CAT-SIB? And I told you you'd know that term by the end of the day? You know it now? Okay, good. The original CTSIB or CAT-SIB, which some of us think about it as the old foam and dome. Did any of you guys learn foam and dome test in school? So the foam and dome was where you stood on the hard ground, then you stood on foam, basically stood on the hard ground, eyes open, eyes closed, stood on foam, eyes open, eyes closed. And the dome was where you would stick something over their head, like a lampshade on the head, to kind of limit their vision. So instead of eyes open, eyes closed, you fool their vision, so they can't really see. But this CAT-SIB is sort of that idea. And so this one does a modified version of that. You stand, eyes open, feet flat on the floor. You have them stand, eyes closed, feet flat on the floor, and then stand on foam with your eyes open, and then on foam with your eyes closed. So again, it gives you that whole variety. And it hopefully will get redundant with you, where when you start looking at the different tests, you see how they all sort of incorporate their own version of the CTSIB, their own version of the Romberg, their own version of the biomechanical constraints. Okay, and then stability and gait, they do timed up and go with the dual task as well. So you can see why this is a great, well-rounded test, but you can also see why people don't do it often, because who has time? A lot of times you are very limited and they want you to get on to the next patient. So you may have to pick and choose who you do this test on, because they have to be fairly high functioning to allow you to do the test in an efficient period of time. Otherwise, it may take forever, and then again, if they're not high enough functioning, they're gonna not do well anyway. So the ceiling would be too high. Now the mini best is, so what happened is they came out with this best test. I think it was pretty acclaimed, well acclaimed from a research standpoint, but I think a lot of clinicians right away the feedback was, I love the test, but I just don't have time to administer it, it's too intrusive. So they came up with the mini best. So the same authors produced the mini best. And so I wanted to look at that mini best together. I think all of you should have a copy of it on your desk. And those of you at home can go on Best Test US and get a copy of it. But an overview of it is basically, it looks at sit to stand. It looks at, so sit to stand, common one, Berg, Tinetti, all, very often have that same measure. Rise to toes, so it has you go up on your toes, and measures your ability to go up on your toes and maintain that. Single leg stance, again. So the rise to toes is not a common one. I don't see that very many other places, but the single leg stance, pretty common. I see that, you see that in a lot of tools. Compensatory stepping forward, backwards, and lateral, which I love. I think that's something you don't see in a lot of tests. And if you have somebody who is an ambulator, it's a really good thing to add into your repertoire, because it's going to give you a lot, especially if you need to challenge them and you need to show that they have a deficit. So those people who, they get in and out of bed, there may be supervision level for a lot of things, and they're really rather independent with a lot of things. It's hard to justify that they could benefit from therapy. But if you can show some things and you're able to quantify it and show risk, so you have a standardized test where a poor score indicates risk for falls, that's your justification that they need skilled intervention right there. Okay, so the forward stepping, lateral, and backward stepping. Eyes open, firm surface, feet together. Is it getting redundant? I hope you're seeing it. CAT-SIB, right? So you got your CTSIB. So eyes open, firm surface, but this one has feet together versus wide apart. So it's a little bit of a challenge for your basic support, a little bit less somatosensory feedback, but eyes open and it's a firm surface. And then right to the most challenging position, which is eyes closed on a foam surface with feet together. So that's a very challenging situation to be in. But if they don't do well, vestibular. You gotta look at their vestibular system. Incline, eyes closed. So basically you're standing on a ramp, incline with your toes, and you close your eyes. I thought that was an interesting one that they chose to keep on the mini vest. So basically, many of my patients might fail, but it's not because of any kind of sensory, like a sensation issue. It's more that they have a lack of range of motion. So if you're looking at a general geriatric population, so many of them have the lack of dorsiflexion. Would you agree? Yeah. So you maybe put them on a ramp, toes up, and they just all of a sudden they can't do it. But It may be a sensory impairment problem, or it very likely could be a range of motion problem because their butt's sticking out and they just can't be in that position. Changing gait speed, so this kind of comes right out of the dynamic gait assessment or the functional gait assessment. Dynamic Gait Index, DGI, versus functional gait assessment. Changing gait speed, walking with head turns horizontal, and walking with pivot turn, stepping over an object. All of those are directly off of those other tests. Not that they copied them, but they're good tests. They're good pieces of a test. And so they're going to help you look at somebody who you want to be a community ambulator is going to have to be able to walk and look quickly one direction to the other, to cross the street, to go through a parking lot, to go down the grocery store aisle and look at what they're looking for. So you're going to need to be able to do those things in order to be able to resume a community type life. Walking with pivot turns, you're very often going to need to be able to turn around when you're out walking, stepping over obstacles. And then there's the timed up and go with the dual task. So it only gave you the dual task, not the regular, just the dual task, which again, I thought was interesting. So that's the mini best. Now, outside authors, another research group did a study and they produced the brief best. So they came up, so now we have the best test, there's the mini best test, and then there's the brief best. So the brief best, I have some copies of it, and it looks at, I believe it looks at sit to stand, single leg stance, push and release, basically the compensatory stepping. I think there's a time back and go. I have to look at it again to remember, but it's a 6-step one. So what they did, so the mini best, my understanding from reading the research was they narrowed it down and they looked at the test as a whole, which ones they thought were the most meaningful. But the people that came up with the brief best, from what they published is they said they looked at each of the 6. I think they basically were very complimentary. They said we really loved the best test. And we loved when they came out with it, and we loved the idea of the 6 different sections being able to indicate where the primary problems would likely be. But we didn't like the fact that when they did the mini best, they sort of aborted that idea. Instead of keeping it in 6 separate categories, it was just sort of a global picture. So what they did was based on their research, they defined what was the one thing in each of the 6 sections that they felt was the best indication of that problem. So they came up with 6 pieces, 6 indicators, and that's what the goal of that was going to be, is whichever one they did the worst on is where you could focus your care, because that's the biggest problem. So if it was biomechanical constraints, you look at their strength and range of motion. If it's more, anticipatory postural reactions, you look at things like reaction time. So it basically is meant still to guide your care and to sort of indicate what's the biggest problem they have. How are we doing on time? 1:55. Do you guys want to take a little 5-minute break? Yeah? Quick 5-minute stretch? It's 5 till 12. Let's just do a quick 5 minutes. A couple of you look like you're floating. But I'll be here if you guys have questions.
I worry about the liability in a way of like doing that compensatory test.
Yeah.
I mean, I know you do it at a much higher level of folks. I would probably never use it in a nursing home. But I have a hard time even doing the TENI test. Some of them not
You know when you might end up using it on your folks that have a little bit more of a cognitive problem.
Mm-hmm.
Meaning they can ambulate, but they've got, do you get that type of people?
Yeah, occasionally with the Alzheimer's or the very, they walk real good, but they walk into other people's rooms.
Right,
Yeah.
right.
Yeah.
But you might also identify some balance problems that are hard to put it, hard to put in
do it
place.
so
They don't
well.
really have to follow your directions to do this.
Um,
You can just say, stay still, stay there, stay, don't move, you know what I mean? And then you let go.
Right.
Versus telling them,
Have you
look
had-
right, look left, look up, look down. They may not be able to do those portions.
I thought about this as all the orthopedic surgeons and stuff, they have you sign this form that says, you could die and you can have blood, you can do it.
Right,
We don't do that.
yeah.
Hey, sign this piece of paper.
Your skilled nursing facility probably does.
Yeah,
A lot of
protect
times
you
when they
from
come
that.
into your facility,
Yeah.
they're given like a very thick document, and then they sign a piece of paper that probably somewhere in there said,
We're
your
not-
therapist might kill you one day, but you're
You're
taking that
you're
liability.
taking that risk. I would like to know that because, I am, I just think, oh my gosh, I've just met this person, or I have them do the get up and go, but I'm not supposed to touch them. Well, how do I even know they're safe?
I mean, you might have to have a second person.
yeah, a
You know,
guard.
you might have to have your rehab tech stand next to them and observe them, and you may not be able to do the test. If you
Yeah.
truly think
Not sure
it
about their
doesn't seem
ability.
safe,
Right.
then you can say unable to, perform the test. It
Or
just
do it
wasn't.
after you know what you feel they can do after a later date and then add it to their.
Well, that could be part of your plan of care, that they
Okay,
will pass that
care.
test,
Right.
but they can't right now, can't even
Yeah.
administer the test because the patient is not safe to perform without physical assistance.
Right.
You know,
The genetic confuses me a little bit too, because, when you go over it, it's like, okay, can they balance with their feet apart? Okay, and then it says, can they balance with their feet together? And if they can't balance with their feet together, they're sure not gonna be able to balance with their feet together with their eye closed, and they're probably not gonna be able to balance with their feet together and pushing on them. It's like, they're all zeros,
Right.
so anyway.
Well, if they're all zeros today,
Yeah,
do you think based on your findings, they could improve on that score?
right.
Because actually sometimes it's nice. It's like if they're max assist with a transfer, but you
You got
think
somewhere to go,
you,
right?
well, I mean, you really do
It
think
shows
it's
improvement.
probable that they will become independent or better in some way.
Yeah.
So the question is, don't do that test if you don't think they're ever gonna be able to do that test.
Right.
Because then it's gonna look like a failure on your part. You know what
Yeah,
I
I
mean?
never made progress
So-
on this test. I'm
right.
gonna use a test I can't make progress on.
Yeah, do a test that you think that there's portions at least that they will get better at.
Mhm.
So, I mean, that's where you're choosing a test, which is, it's frustrating. Some situations, they force you to use certain tests. I think in outpatient, aren't you forced, home health, I think you have to do the time up and go. There's a couple tests that
There were, yeah.
are required. And I think if you take away the clinician's ability to choose the test, you might end up with a test that just really isn't helpful, or maybe gives you a false picture that they didn't improve.
Yeah.
The nice thing about standardized tests is it gives you room for improvement. You
Right.
can pick up on a little bit of an improvement, 10%, they got 10% better, there's a 10% increase in their score.
Mhm.
Maybe certain things that they needed to do better on, like one field, one part of it, they improved on.
Right, if you can just go up 1 or 2 points.
Yeah.
We have this in the nursing home, we have those outcome measures, which, I feel like, well, why don't you just read my evaluation,
Why don't you read
Now I'm taking my eval and I'm itemizing it out for you or something.
Yeah, well, we're test
Like
subjects.
extra work.
That's where I'm hoping to save you some time, it will be your evaluation. That is your evaluation.
Right.
So you don't have to do duplication
Mhm.
in your eval, you pick the standardized
Pick a
section
couple
values, and
tests
that's
and
your
see.
eval.
Right.
Yeah.
That would be nice.
You got copy?
I'm sure we're not too far behind, I think we're doing good. What time did I tell you we're done, 12:30? A lot of you didn't think you needed a break, and you took more than 5 minutes. You guys about ready? How many were missing? Well, if you're ready, so hopefully that was just an introduction to standardized tests. And the idea that you have very low-level tests, some of the ones that are not, that we didn't talk about, are even lower level. I know when I was in the skilled nursing facility, we sometimes would use, there's a sitting balance scale, or I think it's the Ottawa sitting scale. So there's a couple of sitting scales. Some of them are designed for more hemiplegic patients, and you can tell because it talks about the affected limb versus the unaffected limb. But some of them are useful if you've got a lower level patient, and if all you do is the Berg, if the Berg is a high level test for that person's ability, and they're gonna fail, and you think they're kind of always gonna fail, they're never gonna be very good at it, or at least for now, they're so low level, you might find another standardized test, which again, allows you to focus in on sitting balance, and instead of it just being one goal, it can turn it into a little bit more of a broad goal, because it shows you that you can have them sit and reach. There's a functional reach in sitting. There's the push and release in sitting. So it gives you other ideas, and it might help someone have a bit of a more broad treatment program and a more broad area for improvement based on the type of testing that you do, rather than just what is your sitting balance. And then you can have all these features of sitting and scooting, things like that are in there, hip hiking. Again, it can give you a little bit of a broader picture of their ability to sit and transfer. So let's just briefly go through gait. Gait analysis, to say that we're going to do any kind of a gait analysis conference here today is an understatement, because true gait analysis is very, very complex. So I just want to just very briefly look at the site, the different phases of gait, and kind of what the common problems are with older people, and to allow us to just look at some of those key features. The loading response is the most challenging period of time for a patient. It requires the most muscle activity, and so basically your leg is out there and the weight is going on the leg and they're accepting the weight. So the weight is being transferred from one limb and accepted onto the other limb. It requires, confidence, certainly, but you see it has a lot of muscle activity. A lot around the hip, the glutes, the hamstrings, the hip abductors are required. If they have weakness of the hip, pain in the hip, any of those problems, they're not going to have a good loading response, or they're going to be afraid, and they're just not going to put the leg out there very far. The quads need to be active. They need to be able to catch them and control and accept the weight. If they have pain in the knee, in the quads, weakness in the quads, all of those features are going to cause a problem with this portion of gait. They need dorsiflexion. So they need to have range of motion and dorsiflexion strength in order to put the weight on the heel and have it stay on the heel and slowly transfer it onto the whole foot. So lack of range of motion or strength, or it could be pain as well if they have foot pain. So basically, this is the portion of gait that is the most challenging. And so you may have somebody who has a deficit, and therefore they don't even have this portion of gait. They just aren't capable. During mid-stance, so as the weight starts to shift over the foot, so the weight's already on, they've accepted the weight, and the weight now shifts over the foot. You still need hip abductors. So when you think about somebody who doesn't have a hip abductor strength, they're going to do one of two things. The pelvis isn't even a drop. So they have, I call it the Tredelner gait. That's what I learned, is when the pelvis drops. Or they're going to lean over. That requires them not to need those hip abductors. So they may waddle. You've probably seen the people that waddle. Or they may walk and they just have this sort of kind of gait. So, hip abductors, looking for those types of things so you know how to fix it. Quadriceps, you need the quads at the beginning, but as soon as you pass over, you don't need the quads anymore. So basically, they may hyperextend the knee. So you may have someone who kind of walks with this, kind of throws their weight ahead, or they hyperextend their knee. And it may be because at one point they didn't have quad strength, or they don't have quad strength now. And so the question is, can you correct it? And if it's a bad habit. And so I have a young guy right now who's ambulatory, but he has significant altered gait, but he's been doing it for so long that it's really hard to turn it around. So when you have somebody who maybe the gait abnormality it was necessary at a period of time, maybe they had an arthritic flare-up, they had an injury or something like that, so in order to compensate, they had to do something in order to be able to walk and tolerate the walk, but now they don't really need to do it anymore, they just do. It's a habit. So in that case, you might need to correct it and have them work on something. Because I always say, one of the things I love saying is, if they do it poorly, if their performance of some task is poor and compensated, having them do it over and over again isn't going to fix it. So you've got to try to correct the bad patterns and behaviors and then have them learn a new way. So plantar flexors and intrinsics of the foot. So basically at this point they go from needing dorsiflexion to needing plantar flexion to control your weight shift over. And they start needing more stability in their forefoot. So for those people who have the neuropathy and they have poor intrinsic muscle activity and poor sensation, they're not going to do this. So their gait is going to start resembling something a little bit more constricted. They're not going to be able to feel comfortable with the weight shift over the foot. terminal stance. So basically, when you get down on the terminal stance, you're about to put the weight on the other limb. So you still need your hip abductors. You need, at this point, your hip flexors. So you need your iliopsoas to control. And you need your plantar flexors and your intrinsics to be able to push off. So it's another important time with a lot of muscle activity. The more muscle activity you need during a phase, the less likely they're going to have that if they have deficits. They're just not going to have a good gait. Pre-swing, their iliopsoas is still controlling the movement on the other limb. Now, this is where you have altered depending on the speed. So if they are going faster, they need knee extensors. Otherwise, the knee will flip up. If they're going slower, they need their knee flexors. So when you're walking really slowly, you have to be able to flex the knee and hold it up to get it through. But if you're walking really fast, the energy level is going. So a lot of us don't run into that. You'll see it more when you have people who are bodyweight support ambulation, treadmill training, things like that, which I see more often probably than a lot of settings. You'll start to see these things come out as muscle weakness will reflect in certain movements being ballistic when they should be controlled, or you could injure a joint if you do it over and over again. So, especially with body weight support treadmill training, you got to be careful that you're walking in a way that's safe and that you don't cause them to have injuries just from the therapy that's being done. Plantar flexors, so you're still pushing off. During the initial swing, very similar, so not a lot has changed, and you're just starting to get that leg swinging. And then mid-swing, you just need dorsiflexors. So I think when you look at mid-swing, and you look at the two limbs, I mean, this is a very limited look that we're having, because we're only really looking from the hips down, and we all know that some stuff upstairs matters too. But if you look and think there's not a lot of muscle activity necessary or range of motion necessary for this portion, and this is what your really diminished patient's weight gait is going to look like. I call it short shuffling steps. They're just kind of taking these little steps. And so that's what they end up looking like when they have a limitation. It could be fear, and it's not necessary, but they're imposing these limitations on themselves. It could be necessary. They literally cannot step. So if you notice somebody that walks like this, and you're asking yourself, well, gosh, they come walking into your clinic and they do these short shuffling steps, you're going to want to know why, right? So what would you do? I'd do some standardized tests, but it's just that noticing that right away is going to guide my direction on which way to go with a standardized test. So you could go any which way, and my decision might be just based off some things that I see and my perception of that person. I right away may sit them down and do a confidence scale. Because right away I look at them and I think, scaredy cat. Have you ever done that where you just immediately think, I got a scaredy cat on my hand? You can just tell. So before I do anything else, I'm probably going to do a confidence scale just to capture their initial fear. You know what I mean? So get their baseline. And then after that, then I'm going to start doing my standardized test. I may need to do a preliminary one. It may be real aggressive, like get them up and put their feet together and close their eyes. Something kind of aggressive, or have them try to stand on one foot. Just do something initially to tell yourself how high functioning should they be. They don't look high functioning. They look like they have a serious balance issue because they're walking like they ought to have a mobility aid. They ought to have a walker. You know, have you ever had people come in the door and you're like, boy, that person needs a cane or a walker, and you're asking them, do you normally use a cane or a walker or something? And they tell you no, and you're thinking maybe they should. Well, then to determine, should they? I don't necessarily think you should just give them one. You've got to figure it out first. Just like don't give them a pain pill if you haven't assessed what their pain is and what makes it better, what makes it worse. Don't automatically assume they need a walking assistive device. So right away you're going to assess, do they have a problem or is it fear-based? And then what is the problem? You know, and that way by assessing them, you're going to do the right thing. So that's where you pick your standardized assessment. You may start with whatever your go-to is, a burn. And then you think that wasn't enough. We need to step it up a notch. We need to do a functional gait assessment. Or we need to do something lower level because, and I need to test their sensation in their feet. It's not that they don't have good physical strength, but boy, they're having vertigo like you wouldn't believe. And so the vertigo is causing them to walk as if they're walking on a floating ship that's rocking all over the place. So again, the way you're identifying the problems is going to guide your care. and you're gonna help figure out what the problems are, and then you're gonna treat the right thing. And then terminal swing, more muscle activity is needed. And again, if they don't have confidence, they're not gonna get that leg way out there. If they don't have good balance, if they can't stand on that left foot, so if they, I can, but I'm not doing a good job of it. So if I can't stand on my left foot, there's no way this leg is gonna be way out there when I go to step on it. Because I'm not gonna be confident enough to sway off of this leg and then fall onto that leg. I also have to have the strength, confidence in this leg. If this leg hurts, again, I'm not gonna fall onto that leg. I'm gonna say, oh, that's gonna hurt. I'm gonna be scared, and so I'm not gonna do it. So much goes into it. So watching somebody walk, I may immediately say, hold on a second. Let me see you stand on your left foot. Okay, now stand on your right foot. Okay, can you close your eyes? Stand there, close your eyes. Right away, that quick question, what does that tell you? Right away, I'm figuring out, is there strength or range of motion or sensory limitations in this leg? Like, they've got terrible neuropathy in this foot, and therefore they're not wanting to spend time on it, versus they stand on this foot and they're okay. So it immediately explains why their step length on the left is smaller than the step length on the right. So you can kind of see it, and then you go down, you do your monitoring testing on the right foot, left foot, ask them, are you diabetic? What do your blood sugars run? You know, things like that. It can lead you kind of down the path that's going to give the best bang for your buck if you're a battle. Okay, that was a long-winded. Okay, so basic overview of gait. There are lots of gait assessment tools. What I find are, and what science will tell us, is all or nothing are the most reliable because they're hard. Gait assessment is difficult, but there is one, and I have some examples back there, but you can also find them online. There's I think it's a Rancho Los Amigos gait assessment tool. And basically it's just it's a flat tool. I think I might have a copy of it here somewhere. It's just a basic tool that has yes or no. Do they have this problem or don't they? This is the tool, looks like this. It's called the Observational Gait Analysis Checklist, adapted by the Rancho Los Amigos. So basically it shows you, the good thing it does is it blacks out any area that they can't have this problem. So you're not gonna make a dumb mistake and say they have a problem that they're not capable of having, you know what I mean? So that a problem you can only have during the swing phase, you're not gonna accidentally say that they have it. So what it does is you can look down the list, and it basically says during stance and swing, and it breaks it into the loading response, mid-stance, it breaks it into all those little sections, and you look for these things. So do they lean forward with their trunk? Do they have a backward lean with their trunk? Do they have a lateral lean with their trunk? And at what point? Check, 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 where they have those things. Do they have, looking at their pelvis? So you may have them walk a bit. You could record their gait. So if they are not capable of walking for the 5 minutes it takes you to fill this out, can they walk for 1 minute? You can record them, and then you can go back and watch it over and over again and say, oh, how's their pelvis look now? You can even zoom in on their pelvis. Life has gotten easier lately, hasn't it, with all our smart devices? So there's no forward rotation, no contralateral drop, there's no hip, do they have hip hiking? Hip inadequate extension, probably the number one thing I see. Lack of dorsiflexion, lack of hip extension. So if you don't have hip hyperextension, so what does it say? I said full joint range of motion with gait. Hip flexion, you need 10 degrees of hip hyperextension. And 30. Most people have well more than 30. If they're able to sit, they have more than 30 degrees. But what I tend to see that they don't have, especially if they sit a lot and they're not real active, is they have a lack of hip extension. So they may not even get to neutral. And therefore, if they don't, there's no way they're going to have this normal gait. Knee flexion, 0 to 60. A lot of people, especially after having a knee injury of some kind, are lacking that last 0, all the way to full knee extension. Or they may be lacking, we're usually looking for far more than 60 degrees of flexion if we want them to sit to stand effectively or go up and down stairs. Ankle plantar flexion, that 10 degrees of dorsiflexion often is missing. And when you start looking at somebody who you can really right away make a difference. You can right away, if this is someone who is fearful, isn't very efficient, you can right away, if you can increase that hip extension and dorsiflexion, immediately make them more effective. We felt how ankle strategy, how important it is. Engaging a little bit more range of motion right away will make them have better strategies to be able to shift their weight more effectively, suddenly they can stand a whole lot better. And I put in their supination, the pronation supination, which absolutely matters, but when we have low-level people where really a lot of times hip extension, dorsiflexion are the big ones that you're gonna run into, and knee extension. You know, it burns me up sometimes when you read the research studies about knee replacement and they say, oh, when we looked at them 3 and 6 months out, they had resumed previous levels of activity or they had resumed independent daily ADLs, regardless of whether they had therapy or not. And that's justification to not have therapy. It makes me crazy. I'm like, did they do a full gait analysis? Did they look at, you know, can they stand on one foot? Are you guys hearing this and seeing this sometimes? Yeah. So I mean, looking at just whether they resumed, did they resume their previous, you know, independent level of living at home, but have they compensated in many ways, you know? So just because they're living in the previous destination doesn't mean that they're functioning as good as they can. Oh, okay, so that's, again, frustrating, where if we can point out and do counter studies to show that yes, maybe they're living in that environment, but how are they compensating? And do standardized tests to show measurable deficits that could be restored, then maybe we, you know, I'll counter your study with my study. Okay, so going down the line, there's hip inadequate extension and circumduction or abduction. So basically they may be circumducting or they may be hip hiking to get that leg through. Knee excessive flexion, uncontrolled extension, or inadequate flexion. I've seen people who hyperextend, and the younger they are, the worse it is, because a lot of times they get this habit going, and if they hyperextend, they could end up with early onset, real bad arthritic problems and degenerative changes. Ankle and foot, the foot slaps down, meaning, you know, if they were able to get the heel on the ground but the foot slapped down, it tells me that maybe the range of motion might be there, but the strength isn't. Forefoot contact, meaning they hit the ground with their whole foot down. Lateral, late heel off, meaning they're going to walk but the heel's not lifting up, or contralateral vaulting. So in order to swing, I'm going up on my toes to get that left leg through. So, let me see, I think the next one goes into a few examples. Some common things with gait with the elderly is as they get older, they tend to walk slower, they have decreased step length and decreased stride length, and increased stance time, meaning they spend more time with 2 feet on the ground than they spend with 1 foot on the ground. And there's decreased single limb stance. Well, that's what I just said. Less time with 1 foot on the ground, more with 2, and more time in the stance position than in the swing position. Varies, I mean, obviously it's going to vary according to their lifestyle. I mean, you have 2 people of the exact same age, and one is out playing competitive pickleball, I mean, versus the other one is pretty dependent. So clearly just age alone is not a factor, as it's not an alone factor. It's their lifestyle, their own physical ability, their disease processes. So there's a lot that's going to go into the predictability of it. And that's going to be your looking at them, because honestly, both those extremes make a difference. The more dependent person is the most obvious that they can use therapy intervention because they're not independent, and maybe they could be more independent in certain ways. But the high functioning, this is a whole other area of the population that probably can use therapeutic intervention, is a really high level outgoing who is, you know, playing competitive sports and getting out there and doing more than they ever did. And they may be experiencing problems as well because they don't know how to exercise right. Do you guys go to a gym? I used to. I have a membership. Doesn't that count? I'm paying for a membership. I just haven't been in a year. But no, when you go, it's always kind of disturbing, but also a little bit entertaining to watch people and how they exercise. Do you see a lot of people you really just, it's all you can do not to give them advice? I've had people give me advice and it cracks me. It's, okay, thank you. You know, but so many people, you see them doing things that you know is counterproductive. And you would love to be able to have just 1 or 2 visits with this person to be able to give them advice on how to exercise in a way that's really going to be more effective and help keep them independent longer. And so I would love to see that being a regular thing, that we are They see us once every 6 months after a certain point, once a year, so maybe at 65. They see us once for a baseline measure. And then we determine if we think we should see them again in a year versus give them objective measures by when they need to come back and see you again. That would be a really nice thing to be able to do so that we can identify early some problems and we can see what their daily exercise habits are and then give advice to hopefully prevent future decline. Rather than when you see these incredibly bad exercise habits that have been formed and it's hard to beat. I'm sure you guys know people. My dad just thinks walking is the answer to everything. I'm like, well, you don't really walk right, so not really. Or the first 10 steps are great, and then all of a sudden you're doing all these wrong things. I'm like, let's do the first 10 steps, and then do this other form of exercise. So gait deviations and possible causes. So leans forward or knee is hyperextended. I mean, if they lean forward, they're trying to put their weight forward. It might be because their quads are weak. It could be because the knee hurts, and therefore they don't want to extend the quads. They could have post-patellar pain. But whatever reason, they're getting that knee, they're not having to contract. So putting the weight ahead of it is going to keep them from having to use those quads. It could be decreased proprioception, or, I don't even have it on there, but fear. If somebody's knee has ever buckled on them, I've never had that experience. My knee's never buckled on me, but I can imagine if it had, I probably would be like, whoa, I don't want that to happen again. So they may have immediately felt more stable and in control by locking the knee. And so you could develop a habit that may not be necessary anymore, but it's become a habit. I have a couple things that are habits, and you guys probably all have some, where now, like in a hotel bath shower, I'm very careful when I get in, probably more careful than I need to be. But I had a scary episode where I jumped in the shower and, I just did a split. You only have that happen once, and then all of a sudden, now maybe I'm not challenging myself enough, and if you're on a wet surface and you're walking more carefully than you need to be, I think we can all identify some self-imposed restrictions that we have done out of fear at some point or another. And so sometimes you've got to overcome that fear. Not that we shouldn't be careful when we're getting in an unknown shower. We should. But I shouldn't get into my shower every day, like this. So again, you identify these things and hopefully overcome the fear and based on reality, be able to act accordingly. Okay, so leans backwards. They may start out walking well and then all of a sudden they lean backwards. It could be weak back or hip extensors, or it could be fatigue. So they could do okay at first for a couple steps, and all of a sudden they're fatiguing, so they lean back in order to not. It's also a compensation mechanism that can be very useful in a paralyzed patient who doesn't have good glutes. They often will use that, and it allows them to walk independently. You just have to counter-produce that with safety measures. Just like anybody in a wheelchair, they may be great in a manual wheelchair, but you got to counteract that with appropriate exercises every day to prevent injury. So leans to the side, I think we kind of talked about that. It could be that they lean over because the hip either hurts or the hip abductors are weak. And so if they keep walking that way, are the hip abductors going to get strong? Probably not, because unless they're standing on one foot and doing stuff, I don't see any way that on their daily basis they're ever going to use those muscles. And they're going to just continue to either stay weak or get weaker. Foot slap. So the fact that it slaps down tells me their heel did hit. So there could be decreased dorsiflexion strength or endurance. So what could happen is they walk well for a short period of time, and then the endurance problem starts to cause them to accommodate in a way. So that may be that you do focused exercises on the weak area, and then increase their walking as they can do it properly, and help them identify at what point stop with the walking, resume again once you've rested, because I don't want you to keep walking and put yourself at risk for falls or injury. Foot flat on contact could be that lack of range of motion of dorsiflexion. It could be weak knee extensors, and it's a compensation pattern. They push the toes down and it flexes it pushes the tibia back, and therefore it extends the knee. Or it could be a range of motion or strength problem with dorsiflexion. Decreased step length. If somebody has a decreased step length on the right, I want to see you stand on your left foot. If you have a decreased step length on your left, I want to see you stand on the right foot. And that's going to tell me if that's why, or if they say, I can't, and they're afraid, but they can. So it could be fear. Toe out. Anything rotational in the leg is hip related, because that's the only joint that, well, it's the only one that should rotate. So it could be decreased hip strength or range of motion. Okay, so let's do a quick review. This is kind of like case studies. Tomorrow we'll do real case studies, but today we'll just do some ideas. If somebody says I get dizzy when I sit up, I get dizzy when I stand up, what does that make you think?
Vestibular blood pressure.
Okay, so you got the two. So where our differential diagnosis is, how does it feel? Describe it. Do you feel lightheaded, or do you feel like illusion? Like, do you feel like you're spinning and you feel vertigo? So differentiating between lightheadedness, which would lead me to test their blood pressure, orthostasis, or if they feel dizzy, like, and they say I have vertigo. They say I feel like I'm spinning around, and then you ask them to describe it. So tomorrow when we talk about vestibular, you can very quickly try to determine whether it's a central problem or whether it's BPPV, based on when the symptoms come on, how they come on, and how long it takes for them to go away. So dizziness with transfers most likely is either blood pressure related or vestibular related, and you can ask them to describe it, and that'll help you know which one it is, so you can further evaluate it. Flops with stand to sit. They can't control their descent. What do you think? Quads? So it could be quad weakness. What else?
Ankle
Pain,
knee flexibility.
fear, habit, sensory impairment, but for the most part, quads, pain, or weakness. Positive Romberg, meaning you look at them in standing with their eyes open, and then you have them close their eyes and their postural sway goes up. So they have a positive Romberg, and they also have a diagnosis of diabetes.
Feet.
Probability-wise, it's a neuropathy, right? So probability-wise, you're most quickly, you want to go down and test your sensation in your feet. It doesn't rule out the possibility of vestibular, but if you're doing your tests and they have good standing with their eyes open, and they close their eyes and their sway goes up a little bit, it's not like they have a massive problem. But if they go to fall right over, they probably have both a sensory impairment and a vestibular hypofunction, and you're going to need to address both, simply because if both are working a little bit, they should at least be able to maintain some degree of balance. It might be a bigger sway, but if they're falling over like a tree, they're not sensing it, so it could be a vestibular and a sensory in their feet. Unilateral short stance phase, we just said that one. I mean, if it's antalgic, technically, doesn't antalgic mean pain? I think it does. So it could be pain, but also ask them, stand on one foot. If they have a short stance on the left, a short step length on the left, have them stand on the right foot. It could be balance on the right leg, so it's a unilateral problem. So it could be unilateral pain, strength, sensory. Could be that they don't have good sensation in the right, but it's pretty good in the left, so they spend the majority of their time on that left foot. And by testing the sensation, when we start thinking ahead about treatment, a cane might solve that problem altogether. Not for physical support, but sensory support. You all felt how when you stand on one foot and you touch something, your balance improved. If you give some physical, some sensory feedback, again, so you start looking at these kinds of things. Flat foot strike, we just talked about that one.
Weak dorsiflexion.
Weak dorsiflexion, lack of range of motion. Less likely but possible is weak quads or painful knee, where they've kind of adapted this because they see that it just doesn't hurt as much if they walk that way. Trendelenburg, the hip dropping, weak hip abductors, painful hip. Agreed? Yeah. Other thing would be maybe leaning over. If they have an increased base of support, so you encounter this person, you're walking in their treatment room or their room, and they're standing with their feet wide apart. What are your thoughts that might cause it? Fear. Okay, so if you're thinking fear because your gut's telling you, scaredy cat, before you do anything, test their confidence. That way you're going to get a good accurate picture of, before you do anything, a good accurate picture of what their fear level is. But then you can just say, put your feet together. Right away you'll see, are they capable? If they can put their feet together but they don't because they're afraid, you got to attack their confidence. Not only their ability to do it, but their confidence so they will do it. You can have them stand on one foot. You could do one of your standardized tests. The Berg would tell you whether they could stand, and it's going to give you a better widespread representation of their ability to stand in a multiple different ways. And if they end up doing really well on it, and they get a full score, then you step it up a notch. You do a more challenging test. Unilateral decreased step length, we already said that one, that's a short stance space. Bilateral, same idea, but either both feet hurt, both hips hurt, both of them have decreased sensation, both feet are decreased sensation, could be both legs are, you just have bilateral hip weakness, could be bilateral issues with just fatigue in general, it could be vestibular, something more broad and widespread would be a visual or a vestibular impairment. Okay. Just again, this is my personal email address. I talked about that earlier today. And this will be the last slide. So the key points for the assessment portion is you want to be holistic. You want to be as widespread as possible, but you also want to be efficient. You want to address intrinsic and extrinsic things, and both of them are going to be really important. Extrinsic factors arguably might be quick. You can address them and change them right away and make the person safer right away. Or they could be hard because it could be that you need lighting features or new flooring in their home. So, again, it could be big or small things. Intrinsic factors, the same idea. It could be you could restore something very, very quickly, meaning they were fearful and you do a great, well-rounded evaluation and address their fear levels. Or it could be really slow and long, and there could be things that can't be addressed. But at least what you're going to do is have a well-rounded evaluation, and you're going to look at the reason they have an imbalance and realistic about what their outcome could be. What could you address, and make sure you're not spinning your wheels trying to change things that can't be changed, and that you attack the things that are the biggest problem and make the most difference right away. Also, multidisciplinary involvement. We are globally very good at being holistic. I think as an industry, PTs and OTs for sure are very, well-rounded, but we can't know everything. I mean, we're all going to have those areas where if you're looking at something you can't explain why, get a referral. Especially like if this is all you're getting today and vestibular, you see signs of vestibular problems, get them to somebody who has experience with vestibular issues. And even on a neuropathy standpoint, if they need to go see somebody about their diabetes, I'm not the one that's going to train you how to eat and cook and all that kind of stuff. I can start the process rolling, but you're really going to need someone to advise you on how to check your blood sugar and all those things. So you're going to identify things that you want them to get more, and don't be afraid to refer. Okay, that's the end of today's portion. So thank you, those at home. Email me your questions.